right into the clinical infrastructure piece. I would invite the panelists to, we're going to start on this side of the room. Is that right? These set of over here?
This side.
This side. So the
Over there.
yeah, if the panelists could head that way, and then the speakers, to the extent the first speaker can come here. What we really took away in terms of clinical infrastructure, the findings, is that there is a tremendous capacity in the state already to support clinical research, both at regional medical centers and community-based providers. So, and I'm saying in this case, clinical research being the ability to work within a clinical research protocol, so an IRB-approved protocol, doing human subjects research, working with those patients. And so we know that capacity is there. We'd like to be able to leverage it. And then a number of the centers that were involved in the listening session also sort of echoed that desire to really expand that capacity and that infrastructure, with particular interest around stem cell regenerative medicine. So we weren't necessarily introducing something that they were not aware of. What they were really interested in hearing about is ways they could sort of engage into those opportunities. You'll hear today a number of specialty care centers out there in oncology, blood, and neuro that, again, see opportunities through this program and give some ideas about how this program can help advance that in their community. And the other piece that, again, you'll hear about is, many of these centers have worked with Alpha Clinic sites in the past. And I want to be a little bit careful to be clear here. It's not necessarily that centers have, the Alpha Clinics network represents a lot of the major medical centers. They may not be working with the Alpha Clinic directly as of now, but they have worked with those centers. So they've worked with the City of Hopes of the world, with the USCs, with the UCLAs. So again, there's already a connectivity around clinical research. And so the idea that moving that to the stem cell regenerative medicine space is could be a natural transition. So with that, I'm going to not talk about workforce development and invite our lead presentation. Do you want to just, you've got the slides, and I'll let you self-introduce if you don't mind.
Of course.
Running out of breath.
No, absolutely. Thank you.
Sorry. My bad. I stole your
Thank you.
thunder.
Not at all. All right. Well, thank you. And thank you for the kind invite. I'm Sandeep Patel. I'm a professor in medical oncology at the University of California, San Diego. And I'm here to highlight some of what we've done in terms of community outreach. I think really when we think about what we're doing in terms of clinical research, our patients are in the community, and taking care of the patients is key. I think it's going to be hard to follow such a nice talk by Katie and Veronica. But I did want to quote something Veronica said that I think really relates to our mentality at UC San Diego. And that's, and I imagine for everyone in this room, and that really is, we're not here for ourselves, right? We're here to do something for other people and try to help them. And you're going to hear from our panelists, who I'll have introduced later, some of the things we're going to be doing to really ensure that we take care of everyone in the state and take care of all Californians, and really increasingly with the impact of our research, people not only throughout the country, but throughout the world with the innovations that are being developed here. And so it's my honor and privilege to talk a bit about what we're doing at UC San Diego. And so within our CIRM Alpha Clinic, we currently have 62 clinical trials, over 550 patients enrolled to date. We have expertise that's distributed throughout all the different specialties at our institution. So whether they be metabolic disease, neurologic disorders, oncology, and increasingly pediatric diseases as well. And so the idea that we really want to touch all the different aspects of health that can be benefited through regenerative medicine, cell therapy approaches That's really our goal at UC San Diego. We have advanced cell therapy lab services for cell manufacture. This allows us to accomplish our goal in delivering cell products for which industry may not have a potential incentive to develop, especially in some of the pediatric and niche diseases where we've invested in. We have a clinic within our Komen outpatient pavilion where we take care of these patients with a dedicated APP team, pharmacists, and staff that really allow us to benefit our patients, both in-person visits as well as televisits, which we've increasingly utilized to take care of our diverse populations that live throughout Southern California. Because increasingly, not only do we serve San Diego County, which is one of the largest counties in the entire US, let alone Canada in California in terms of population, but also, moreover, Imperial County and Riverside counties as well. We have an inpatient service, as many of these interventions take place in the inpatient setting. This is the Cell and Regenerative Medicine Service. This is staffed by a team that includes APPs, but also trainees. We actually have a fellowship program where one of the key goals is training the next generation of clinical and research staff that are involved in cell and regenerative therapies. We just had our inaugural fellowship match. And this is part and parcel of how we try to have folks grow up within the program, including in the Bridges program, the Spark program you heard about earlier, starting to understand what we do in regenerative medicine in high school, hopefully joining us in college, medical school, residency, fellowship, and then becoming faculty. And so really, we talk bench to bedside, but here training from secondary education all the way to faculty is one of our goals, because this is a very unique set of therapies and it requires very unique expertise to communicate these therapies, as we heard earlier from our patient advocates as well. And then finally, the Division of Regenerative Medicine is a division within the Department of Medicine within our institution. And Dr. Kat Jameson is our Alpha Clinic Chair, but Division Chief. And we've been very fortunate to have not only funding from the state, but also philanthropic funding. Here we see a photo of Denny Sanford with our Chancellor Pradeep Khosla and Division Chief and Director of our Alpha Clinic, Kat Jameson, and the characteristic blue logo. Since we're not Division I, we get to pick whichever color we want at UC San Diego. And so I think the key thing when we're talking about patients in clinical trials is access. When you have a disease, the ability to access healthcare is the biggest barrier. There have been multiple clinical trials that have shown when we talk about disparities, especially in oncology, we can bring those away in the VA system, for example, where I rotate and help lead the National Precision Oncology Program. And that's because when you provide access, you can get rid of some of the inequities that we see. And so our mentality at UC San Diego is we need to reach out to the community, not just have patients pulled in, though there are some niche interventions that require expertise. And I described that team earlier, but the idea that we need to get out in the community, and increasingly with virtual medicine, for example, we've been able to do that. I wanted to highlight one of our closest collaborators here at Eisenhower Medical Center, which you see here in Riverside County, Stephanie Farrell, if she can raise her hand, not to embarrass her, but we've been working together for 5 years on how we can best take care of patients in the Inland Empire. And it's not simply refer them to us and have them drive to us, because that's, if anyone's done that drive, that's a very intense drive. And when you're not well, that can be a problem, but really how to partner and to do the things that can only be done in San Diego, but to have everything else done as much as possible closer to the patient's home in the community. And you're going to hear more about Eisenhower Medical Center. San Diego County, of course, a very diverse county, in particular for Hispanics, patient population, Asian patient population, and the most number of Native American tribes is actually in San Diego County, which is a lesser known fact. And so the idea that we want to reach out to the communities that we serve, not only in the county that we're in, but the counties adjacent to us that we can help. And so Riverside County, and you'll hear more about this from Stephanie, Eisenhower Medical Center serves a predominantly Medicare community, so a more geriatric population, an LGBTQ plus community, and finally a Hispanic community as well. And so lots of areas in which we can help communities that really represent the diversity and the power of our population. And in Imperial County, which is the county immediately adjacent to San Diego County, this is a predominantly Hispanic county. Many folks are binational and will go back and forth for their care. UC San Diego Health now operates El Centro Regional Medical Center. And one of the things we're going to talk about is how there are different stages of partnership based on what the community's needs are and what we're able to deliver to the community into their backyard. But I think it's important that this is a bidirectional communication. This really has to be a dialogue, not a monologue on what is needed. Fundamentally, the trials are there for the patients, right? The patients aren't there for the trials. And so how do we make sure we get this bidirectional communication, this dialogue? Well, we have multiple different ways to ensure that we're serving the communities that we want to increasingly, hopefully be seen as being a part of. And so we have the Community Accessible Regenerative Medicine Acceleration Program, or CARMA. We have community advisors. We have a DEI, Diversity, Equity, Inclusion advisors as well, and a community advisory board. And this isn't, alphabet soup for the sake of having these are actual committees that we meet now virtually for ease, and we get guidance and we act on that guidance. And it's important that the community has the stake at the table. They understand what we offer, and our goal is to just augment what can be offered and amplify what can be offered close to the patient's home where they prefer their care. If you look, and you'll hear more about this from Stephanie, Eisenhower Health very much recapitulates the county's population, and San Diego County, as mentioned earlier as well, shows that we have a Hispanic plurality and also multiracial. And I'll point this out in clinical trials. The single fastest growing category in clinical trials at UC San Diego is multiracial. And defining what multiracial means is actually quite complicated. And this is something we're actually working on with our population scientists, such as Dr. Elena Martinez, because each group has different needs as well. And so we've had a partnership for at least 5 years. Stephanie and I routinely text each other in terms of figuring out how we can best help patients. And as we heard from others earlier, it's really about doing what's best for patients closest to where they're at. And so what does this partnership look like? Well, it's integrated clinical research teams. We're both on the same EMR, and so we're able to access each other's data, and we have data use agreements that allow us to do that. Because it turns out during the height of the pandemic, clinical research was mainly done with remote monitoring, right? And so we can rely on each other's electronic tools and video visits to make sure that we can minimize the friction that a patient has in terms of interacting with the health system, but equally so, decrease the friction between institutions. In-person visits, we actually have faculty go out, including myself historically, to Eisenhower Medical Center, and also telehealth in between. And as I mentioned, for El Centro Regional Hospital, we actually are the health system provider now for that institution. And then referrals to UCSD is needed. And I really want to stress the referrals are for those interventions that really UCSD is uniquely suited to provide, and many of the other Alpha Clinic sites are suited to provide. And one of the advantages, it's very much felt to be a bug, but it's potentially a feature of what we do within CIRM, is many of our interventions, they're not like chemotherapy, right? Or targeted therapy that's every 2 to 3 weeks. They're usually one-off therapies. Now it's an inpatient admission, for example, for the cell therapy intervention. That can all be done in San Diego. But then the follow-up visits, for the most part, if they're standard of care, can be done locally. And we try to work, especially with new investigators designing studies, to think about this, because the idea that only patients who live near an urban center getting their care is anathema to what we're trying to do as an institution and as CIRM more broadly. And so just to give a flavor, I showed you what UCSD does across different specialties. This is what Eisenhower does, and Stephanie's going to show you more about this. But the idea is these studies reflect the needs of their patient population. And so for those interventions for which UCSD may be uniquely able to augment those efforts and reduce the friction for those patients, I think that's really key in ensuring that we can give these therapies to patients where they're at. And so we really have a hub and spoke model when you think about how we work with partners. Our goal is to serve a diverse population. These are our patients, right? San Diego County, Riverside County, Imperial County. We want to have a diverse trial portfolio across diseases that reflects their needs. And as mentioned, the diverse populations in particular, we've seen in our clinical trials are Hispanics, Asians, LGBTQ+, a geriatric population you're gonna hear about more from Eisenhower. And then what is multiracial? And we're still at the beginning stages of understanding what the unique needs are, and it's unlikely to be one size fits all, and it's unlikely one label is able to capture the total complexity for this group and the needs that we need to address in order to serve that population. And then our collaborations, as mentioned, it's a hub and spoke model. We work very closely with Eisenhower Medical Center. You're gonna hear a lot more about this from Stephanie later. She's phenomenal. And then also, Eisenhower has capabilities that are not quite yet there for El Centro Regional Medical Center, though we hope to get there. And then the idea really is to get as much of your care in your backyard as you can. And then for those, ocular injections, right, for stem cells, or those cell therapy cancer treatments that are one-offs, maybe you come to UC San Diego for those, but we try to distribute the follow-up so that you can do it closer to home, because these are folks, their lives are in their homes, right? And so we're asking them to take off from work, take off from taking care of their kids. And it's a big lift just to ask someone to come in for something you can do virtually, right? And so how we can decentralize our trials, I think, is probably one of the most important things. And not much good came from COVID-19, but one of the things that may have come long-term, and I wish it had not come through COVID-19, is the ability to do remote monitoring, to do remote visits. It really forced us to pull that Band-Aid off in clinical research, but this long-term may be a benefit for our patients. And finally, partnering. We're all in this, not for ourselves, right? And so partnering with CIRM, patients, caregivers, and community organizations is key to get that bi-directional feedback. We were chatting earlier about artificial intelligence in clinical trials and how AI is the buzzword, right? If you look online. But the honest truth of it is these are tools. And like any other tool, you need to test it out, make sure it's appropriate for the patients, make sure it helps. And so these are, you may have heard about the UC San Diego story around ChatGPT for epic message responses, right? To help assist epic messages. And turns out because ChatGPT can type at an infinite words per minute, they write better messages than doctors. And this is in the Wall Street Journal, you may have seen. But the idea is, garbage in, garbage out, right? And so we want to make sure we train these models with the best information so that we can really create these really hub and spoke models, not only for taking care of patients, but taking care of the totality of their information needs. How many times have we heard in today's session, I went on the internet to find this study, or I went on the internet to find this patient group? So we got to make sure that as we use AI, it's not just a buzzword, that we're not feeding it garbage, because garbage in, garbage out for AI as much as what we provide. And so this is a photo of our first patient. This is with his permission, who received an iPS-derived NK cell therapy, which is, when you're talking about cell therapies, these are typically bespoke. You do a pheresis procedure on the patient. You make a personalized cell therapy for that patient, and that therapy is just for that patient. That works well for rare diseases, but as you start to think more about more common diseases, there's not that scalability. And so the ability to have a bank of cells that are off the shelf and then engineering those cells is something that we've been very keen on at our institution. This is the first patient infused worldwide with an iPS-derived stem cell, and this is through support through CIRM Alpha Clinic. And this is a former military individual as well, and so it's great to serve those who serve us. And so with that, I think we're gonna have a nice panel discussion. Happy to take any questions in the context of that panel. I wanted to introduce our panel chair, Dr. who probably doesn't need an introduction, but Dr. Milan. And then as well as the other panelists that I have here, Dr. Bukhari, Dr. Walters, and then virtually Dr. Liu as well.
Conversation by Dr. Mohammed Bukhari from UCSF Fresno. Dr. Bukhari. Maybe I'll put this on your.
I would like to take this opportunity to thank Sam for allowing me to do this presentation today. And my name is Mohammed Bukhari. I'm lead provider Adult Sickle Cell Clinic, Community Cancer Institute, UCSF Fresno. So just to provide a background of this clinic, several years ago, Fresno and its surrounding county did not have a dedicated adult sickle cell clinic. This created two problems. Number one, patients moving in into Fresno and surrounding areas from other counties who are sickle cell patients do not have a dedicated clinic to go to. So the patient's care is fractionated among various oncologists or hematology oncologists, and we know how much time and dedication and effort is required to take care of complex sickle cell patients. So this has resulted in variability of care and lack of standardization of care. And it has led to increased utilization of emergency department as part of their acute care or even chronic care. The second problem it created is the fact that Valley Children's Hospital, who provide excellent pediatric sickle cell care, but once the patient turned 18 and above and they need transitioning of care, there's no dedicated adult clinic to transition the patients. So patients are then referred to San Francisco, San Diego, and surrounding areas, and it requires a lot of time, effort, resources, and it's just not practical. So this clinic came into existence as a collaborative effort between UCSF Fresno, Community Cancer Institute, and there was initial funding from Pacific Sickle Cell Regional Collaborative Program and Networking California for Sickle Cell Care to provide a dedicated sickle cell clinic in Central Valley, and this will allow both transitioning of pediatric patients to adult care as well as adult patients who are living within the Fresno and surrounding areas to have standardized care. So this is to show the location of the clinic. We are currently housed in the Community Cancer Institute in Clovis. Our patients come from surrounding areas, not just Fresno, Madera, Merced. And the clinic also helps to coordinate care for patients who go to other emergency departments outside the community cancer, community health care system, so that the ER and the hospitalists and other providers have somebody to call with regard to managing this patient. So in terms of patient numbers, even though the clinic is sickle cell clinic, we also see alpha and beta thalassemia patients, and we significant volume of our patients come from transitioning of care from pediatric to adult. And increasingly, some patients also move into Fresno and surrounding area, and because we are part of Networking California for Sickle Cell Care, we get referral from their providers in UC Davis, UCSF when they move to Fresno area. In terms of staffing of this clinic, we have a dedicated physician assistant. Currently, we have a medical assistant as well as a social worker, both of which are funded by Networking California for Sickle Cell, and we have adult provider who is available to provide the sickle cell care. And we are currently in partnership. Our main partner is Valley Children's Hospital Hematology Oncology, where bulk of our referral for patients who are transitioning from pediatric to adult care come from. We are also part of National Alliance for Sickle Cell Care, and we have community partners, Family Resource Center of Fresno, who provide community resources. They help with funding for feeding or housing and other community resources. And then Kayan Wellness Center, who also help provide additional support where needed. In the services provided, and this is very important because as we all know, sickle cell and thalassemia patients are a lot more complicated than our regular oncology patient. There's a lot of time involved, and we provide comprehensive care. We have twice-a-week clinic. We also provide same-day evaluation for acute pain management. We are able to provide infused outpatient pain management on request. We also participate in multiple echo calls, both Pacific Regional, Sickle Cell Regional Collaborative Echo Call, and Thalassemia Western Consortium Echo Call. This is where we help educate our providers, nurse practitioners, MA on important aspect of sickle cell care. In terms of referral, we still are needing to refer patients to San Francisco, San Diego for evaluation for cellular therapy and stem cell transplant. And fortunately, since COVID era, because of telehealth evaluation, this has been made a little easier on families, but otherwise this is very intense on family because of transportation issue, even just time commitment required for somebody to move from Fresno to our referral center for evaluation, and then multiple visits. And then if they are considered appropriate for additional therapy like cellular therapy or stem cell transplant, then a lot more effort is needed in coordination, including housing and all that. And this, I must say that it puts a big burden on patient. Most of them don't drive. So not only on patient, but their family members who have to take them to those clinics. In terms of challenging and opportunities, I think one of our big areas we are working on is securing infusion chair for same-day management, particularly pain management and hydration for patients when they call. And then transitioning of our apheresis unit from downtown to Clovis Cancer Center, and this will reduce the amount of time or frequency the patient have to go to these two clinics. The current situation is that if you are on monthly apheresis, you go downtown, you get lab work done, you go back there and get your apheresis, and then you come to Clovis to see us, and that has some challenges associated with it. And most importantly, we are hoping that community cancer institutes, cellular therapy and transplant, once it comes into being, we will benefit from additional resources that the cellular therapy has. For instance, we will be able to do apheresis in the Community Cancer Institute. This will prevent, or this will help alleviate the time and effort and transportation required to go to various places to get this care given. We are also hoping that, in future, when we refer patients to other centers for cellular gene therapy, if they need collection, if we have the capabilities in Fresno, we will be able to collect the patient there so as to reduce the amount of time patients spend moving back and forth between Fresno and surrounding county. So overall, we are hopeful that cellular therapy probably will also provide opportunities for collaboration with other centers. And we hope that at some point we will be able to deliver all these cutting edge treatments for sickle cell, cellular therapy, gene therapy, closer to home where their family live. So this is the end of my talk today.
You're gonna pass that around, or do we have my hand held? Okay. Thank you so much, everybody. So we have 20 minutes to just kind of tap into some of what's in existence today, both at the academic centers and at the community centers that you've heard about today. And so to just start off the panel, you've heard from Dr. Sandeep Patel and Dr. Bakari just recently. I just wanted to have Dr. Walters, Mark Walters, introduce himself, and then we'll just kick off the discussion. And we really want this to be interactive, because the whole idea here is not to just, kind of present, but to stimulate discussion. So I might go a little bit more provocative in my questions, just to warn you guys.
No, I'm scared. Mark Walters, I'm the Alpha Clinic director at UC San Francisco, and I'm also chief of hematology at UCSF. Department of Pediatrics. I also run the bone marrow transplant program at Children's Hospital Oakland, which I've been there since 1999. And the reason why I moved from Seattle, where I first started to become interested in curative therapies for sickle cell disease, is because of the comprehensive centers that existed there for hemoglobin disorders. And so the idea was that you would build like a pyramid on a foundation of a clinical expertise in any particular disorders that applies to cancer, it applies to non-malignant like sickle cell disease or thalassemia. And so that's been the approach we've taken in Oakland and at UCSF. So the provocative thing that we would like to see happen in this renewal Alpha Clinic era, which is our second iteration, is to get away from the hub and spoke model so much that we've all become comfortable with, and develop a hub and hub model, where what we actually want to develop is access to the cutting edge care locally. And so the way you do that is how Dr. Bakari just presented it. You have expertise in the disorder in the community. And then the challenge to us at the Alpha clinics and at the medical centers is, how do we lower the cost and the complexity of some of these therapies so that it's actually feasible to have a hub and hub model, because we're just not going to have the impact that we need to have until we're able to do that. This notion of doing, most of the care locally, but having to come to, a limited number of centers is just not going to work. Certainly not in sickle cell disease at all, and thalassemia either. So, and I suspect cancer is the same story. So that was the thing I wanted to kick off, Maria.
Fantastic. And so I'd like to introduce our virtual participant in this panel, Dr. John Liu, who is from immediate past president of the Humboldt Del Norte Medical Association and a radiation oncologist. I think, do we have Dr. Liu on the screen? Okay.
Y'all hear me?
A few words, Dr. Liu.
Sure. If y'all can hear me, I'm Join Liu. I'm a radiation oncologist in Eureka, California. For those of you that don't know the more rural areas of the state, we're 5 hours north of San Francisco, and it's about a 5.5 hour drive from Sacramento through some very tortuous, mountainous, windy roads. My involvement with CIRM was primarily through the County Medical Society, and primarily trying to engage the students at Cal Poly Humboldt with area community physicians to look at the application of treatments. And so we're very excited to be involved and hopefully look at some applications of ongoing research in the clinic.
Thank you so much. And first of all, I wanted to acknowledge that this room is composed of such a diverse audience of from members of all sectors of the community. And so I love that one of our participants wrote to me, "What does CAR T mean?" Because we tend to kind of go into our lingo and just start going on and on about big problem statements and don't really lay down the base. So at any time along the way, please ask questions, because if you don't understand what we're talking about, it's, you lose some of kind of the ability to participate. But, today is a very timely time. It's very timely to be discussing the topics that are on today's agenda. We were led off by very inspiring talks of lived experiences by Isabel Duran, by Katie Sharifi, and by, Veronica. I'm sorry, I forgot your last name, but you had such an amazing talk. And what it really led to was, first of all, it was really many emotional responses to all of you, because not only do your heroic journeys inspire us, but it makes us even more motivated to figure out the solutions for the same reasons you have, which is you've seen what's possible when you have the support, when you have access, but you're also saying, I can't imagine what it's like to not have that, to not be understood, to not be heard, and to not have that access. Today, there are about 29 cell and gene therapy products that have been approved. So this is no longer theoretical, it's reality. You've seen some talks, Barbara Lavery gave some excellent, evidence-based research in terms of even approved products, how we have this is a major hurdle in terms of, and love that she gave examples of some tangible toolkits and approaches. And so I would love to touch on that a little bit more in our discussion. And just this year alone, there will be 5 expected approvals for cell and gene therapy, 2 in sickle cell disease, curative therapies or semi-curative. There are some down, Dr. Walters along with others are also developing actual corrective measures, but these are definitive therapies, 2 in Duchenne muscular dystrophy and 1 in hemophilia A. So it's very real. So these centers, Dr. Bakari, the Eisenhower and El Centro, along with our academic medical centers, will be facing even approved products coming in. So here's my provocative question to you, and it's very high level. We've heard from those who've been through this journey, we've heard the gaps and the challenges. And what's available both at alpha clinics, at the community care centers, at starting points, both from community centers that maybe are not even involved with academic partners as Fresno is. What do you see is getting in our way of addressing the challenges that were put forward in the earlier talks this morning? And what do you think can be done with the appropriate amount of funding, real partnerships, and resourcing to address those challenges? And maybe if it's okay, because the virtual speakers always kind of get a little bit of a disadvantage. I'd like to start with Dr. Liu, if you have some thoughts from your perspective.
Sure. Yes, the stories of those that participated in the stem cell research protocols really resonated with me, because the challenges they faced, particularly with Veronica's presentation, are the same challenges that our patients face in accessing tertiary care. Transportation, family support, as well as money to be able to get to these facilities are barriers in which these patients can access these therapies. So often, we're all excited about development of these technologies, but they're going to be of little use if patients that could benefit can't get access to them. So I think I might be coining this new phrase. We always talk about social determinants of health, but there's also social determinants of participation. You can't participate if you don't have a car that works, or have somebody that can drive you when you're feeling ill, or if you can't get childcare for your kids so that you can go to a tertiary medical center to receive these treatments. So lots of potential solutions, but I think we've done a good job identifying what a lot of these barriers are. And I think a lot of this boils down to commitment, funding, and social services that can address these social determinants that keep these patients from accessing these technologies.
Thank you, Dr. Liu. And I'm going to go to Dr. Bakari, because you have a very unique example. First of all, it's sickle cell, so it's topical, but a very unique example of where there is already a very solid starting point of a connectivity and partnership with the academic medical center. But there are also these barriers. So even before transportation, and even before that, there are some upstream challenges in terms of the trust factor, in terms of that information getting across in the right way, in terms of even the primary care physicians really buying in and understanding what this is. So can you share some thoughts in terms of where to go next, starting from where you are today, what still needs to be done?
Yeah, I agree that, it looks like moving patients from their community to academic centers poses significant challenge. The question is whether we can lessen that burden by moving the therapy closer to patients. And this can be done in a variety of ways, in my opinion, and there's no one cap fit all. Some centers have adopted a process where, maybe the academic center or stem cell, cellular, or gene therapy, if it cannot be delivered safely in the local environment, will have some kind of intermittent evaluation by provider from the academic center right in the local area where patient can be seen, evaluated. If there are testing that needs to be done, this can be coordinated with the local center so that by the time patient gets to a point where they need to go to the academic center, they are much more prepared. There's no significant delays because of access issue or transportation and all that. And I think that we also need to strengthen our community-based organization to be able to provide patients with resources and personal experience. Most of our sickle cell patients either do not have transportation or are dependent on other people for transportation. So our community-based organizations provide Uber vouchers, or they can actually call Uber for the patient if they call that, I really need to go to the clinic to be seen because I feel if I don't do anything on Friday, I'm going to end up in the ER and I don't want to do that. So that has actually improved how, patients are taken care of or how they respond to whatever suggestion you give them. And I also think that if you provide enough community resources, it also makes patients more comfortable with whatever care they receive. And I think the community-based organizations also may act as patient advocates, help patients navigate the healthcare system. A lot of these patients have really tough time navigating the healthcare system from insurance changes. And sometimes for some of our patients, we may have to change the insurance in order for them to be evaluated elsewhere. And then we have to change it in a timely manner back so that they can come back to us. So all those challenges, will need multifaceted approach, where we strengthen the local providers, we improve the community-based organizations support for these patients, and then provide enough resources to the tertiary centers so that they can bring the care much closer to the patient rather than hope that patient comes to them.
Thank you so much. And so, Mark, you started off with a provocative question of how do we create hub and hubs, and that partnership where the expertise there's a lot of expertise in the community hospitals. They know how to deliver care. And I would like to, before Mark articulates his vision, turn this over to Sandeep in terms of your collaboration with El Centro and with Eisenhower. So navigation was a topic, empowering community-based organizations. And Barbara Lavery pointed to the fact that effective navigation makes a difference. What would it take to have an integrated or a deliberate program in navigation, empowering community-based organizations, even the drivers, even those who are helping to get to the food banks, or whatever? How do we empower those groups with some toolkits or whatever? And I don't know if you've already started working on some of those approaches. It would be great to hear your thoughts on that.
Absolutely, and a great question. And really the goal is to fill in the gaps that aren't available closer to home, right? And because you want to do as much as possible closer to home. And I think folks have really nicely summarized the gaps aren't just medical, they're social, right? They're food insecurity, housing insecurity, childcare, transportation. And how can we go about taking care of the totality of the patient? And what we've found has been really useful is to have the social worker involved very early in the patient's care. There's actually a model now, and the credit here goes to Dr. Rob Wynn, who's the cancer director at VCU, of having social workers actually in a tumor board. And so, because when you're talking about these therapies, how we can best deliver, how we can support. And so I think models that incorporate social work expertise, I think are meaningful. I think the resources to overcome those barriers, I think we heard about insurance barriers, I think are key. And some things are very tangible things that we can do to advocate, for example. So for example, in oncology, the vast majority of approaches, and I think in a lot of inherited errors of metabolism, for example, precision medicine is key, right? And so one of the bills that didn't get across the finish line this session was on coverage, right, for Medi-Cal, for precision testing. And so I think that's one angle we can improve things on. I think one key is speaking in a language that's comfortable to the patient. I think, Maria, you very nicely summarized, we're talking abbreviations like CAR-T. It's even more complicated when English isn't your first language. And so we're throwing around jargon and acronyms in other language. And so having a diverse workforce in the clinical trials office, because it turned out as we diversified our clinical trials workforce, and many of our coordinators actually had linguistic capability in the languages the patients spoke, there was a familiarity there. And I think that was therapeutic somewhat in and of itself as well. And so I think being where the patients are isn't just geographic, but also social, and then trying to just minimize those barriers as folks have summarized. And I think some of the things that CIRM and pharmaceutical companies are doing, I think are key. I think for the other point that's probably a little more tangible is the FDA is going to be helping us, right, with mandates around diverse accrual to clinical trials. But the number of assessments on a clinical trial that are superfluous in the modern era, especially as you get into dose expansion, as you find a dose, are really a barrier to decentralizing the studies. And I think as we talk about, do we really need a PK every 2 hours for this drug that has a long half-life? Can we use population PK-based modeling? Can we have distributed toxicity assessments using video visits? I think the rope is a little too tight on trial regulation, and it's leading to a lot of friction that unfortunately the patients are having to bear. And so I think loosening that to a safe way, I think it will be key in helping patients.
Thank
you. Is that sometimes home health care, is a key component of, care beyond, the academic center or the community center. And I can tell you the number of times that based on the patient's location alone, there's no home health care available. So you have only one option. The patient has to travel all the way to the clinic, 2 hours in, 2 hours out. And probably sometimes you don't even want the patient to travel. You want somebody to bring the patient in, because if for some reason you want to keep the patient, then, it becomes more problematic.
Thank you so much. And then we're going to finish it off with a provocative question asker here, Dr. Walters. So I'm going to ask you as a kind of a variation of that question. So the hub model. And so now with all of these treatments going toward approval and these qualified centers being set up across in the communities as well as obviously academic centers, what do you see are the barriers to being able? You have a very unique position and you're pushing forward progress in sickle cell and rare, but you also have a view into CAR-Ts, which are chimeric antigen receptor, which is an immune, the patient's either own immune cells as they currently are that are gene modified so that they attack the cancer. It's been revolutionary, and Barbara touched on that. But so what do you see are the barriers to being able to qualify these centers in the communities and have this implemented?
How much time do I have? Well, I can tell you what we're doing now just isn't going to work. It isn't going to have an impact. I mean, this notion of you taking cells out of a person ex vivo, doing the manufacturing, giving them high dose chemotherapy, reinfusing the modified cells, that's just going to be not something that many families and patients will have access to. So, and this is where CIRM could be really powerful, is to motivate, well, what do we need to do to get the therapy to the patients where they live? So it's a lot of it is innovation and technology. So we're learning a lot about gene editing, can we package the reagents in a way we can inject them and then in vivo have the editing occur in the absence of chemotherapy? So yeah, we don't know how to do that yet, but CIRM has the ability to post an RFA and to get a lot of smart people to work on that problem. And that's the step. You have to think about, what do we need to make this accessible? And it's not the model we have currently. CAR T therapy, let's just say children with acute lymphoblastic leukemia, most common cause of cancer in children. We know more and more about the biological features that portend high-risk disease. And we're not going to cure those children by giving them more and more chemotherapy. All we're going to do is cause more side effects. So CAR Ts are going to be introduced early and earlier in the course of that treatment for that disorder, in order to avoid all this exposure to chemotherapy that isn't going to be useful anyway. So right now, if you're a child with high-risk ALL, you have to come to one of the 9 alpha clinics, essentially, or something like it. And what we really need to do is double the number from 9 to 18 to 27. And the way we'll do that is to innovate, to be able to make the product in the hospital where the patient's getting treated in their community. So it has to be a closed system. Just inject the vector, you let the cells multiply, you teach them how to collect the lymphocytes from the bloodstream, and then you do that locally. So we have to embed our trainees in our programs at the alpha clinics in the centers where they're going to live and provide the care. And then we'll train them how to do that locally as the technology advances. So I think that's the vision I have, and you can make it happen, Maria.
Wow, just turned around. So one of the things that you bring up is this innovation, but I want to take it back to the fact that before we can actually deliver this innovation truly in the real world, we have to have an understanding from the community of what the innovation is. They need to trust that the innovation is good for them, and they need to know it's available when it is available. So I want to now, and Jeff Lomax will let me know if we have time, but I want to turn it to the audience, because this is really, this is why we set this up in terms of, I know there's going to be sessions later on this, but in terms of sickle cell and what you've heard from the delivery in terms of the clinical models for this, I'd love to hear from those in the audience, your view of if a key thing that you think can be overcome by creating the vision that Jeff started the meeting off with, is creating these community care centers of excellence that are empowered to do that. So I'm going to call on some people if you don't volunteer. Okay. Adrienne Shapiro I knew she was going to volunteer, but I'm going to call on her anyway. Adrienne Shapiro.
Hi, I am so thrilled. First, I have to say, I'm so thrilled to be here. And as 5th generation mother, child with sickle cell, and carrying the backs of that history and knowing that it's not going to go forward, I'm just thrilled to be here. So to say that. So we really have looked at a lot of the barriers. And early on with the clinical trials, we were able, thanks to CIRM, to really address a lot of those issues: transportation, babysitting, food, education, understanding exactly what people were signing up for. Of those barriers, actually being able to communicate what you're signing up for at this point seems to be the most difficult hurdle. So that's the first one. And how do you do that? So we're doing some things with UCSF where we taking into account, how do people get information? All right. So they get information a lot from their from friends, from family, trusted resources. But then even if you go another level, how do they learn? Some people are sight, some are hearing, some are actual physical things. So we're trying to come up with some samples of materials, for example, with our, oh God, help me, what's it called, that form? The form you signed before you, I'm sorry, our consent form. I'm very tired, I'm really sorry. The consent form of how do you deliver that to people? So you may be reading it, but maybe you're visual. And if you have an option to click on an icon and get a visual message. And then also understanding the culture, right? And the need to have the information being represented by people from your culture, but also the reality of how that team is really going to look in real life. So how do you strike that balance? And so we're doing some testing on that, some things on vocabulary. There's things that we're also talking about, things like emotional IQ. So if you're dealing with a child who has been an adult who has been sick all of their lives, you have to look at what is their emotional IQ. Where are they? How do they feel comfortable? Where do they learn those weird habits of like squirreling cake away in the drawer, right? So cake when you're little, given to you by the nurses meant you were in a safe place. So as an adult, you're going to go back to that. And when an adult provider goes in the room and they find this drawer full of cake, they're thinking, what the heck? You know, this person's not invested in their health. So I think those are the sorts of things that we can do. We've also looked at how do you give people who don't have the privilege or the resources that most of the people who are successful have. So it's not just the financial. The financial is very important, but how do you give them a caregiver who during that period of isolation can really be there and be present? How do you give them the ability to communicate what they're feeling to their care team when they don't really have the vocabulary? Who's that interpreter? How do you use what's in that team? For example, clergy is always there. So how do you get the clergy to come in and give, we think the clergy comes in and gives you spiritual advice, but how do we use that clergy person who is part of that medical team and has access to the treatments, the people that are treating you, to be able to go back and say, I prayed with them, but really what would help is if they could get their pain medicine on time, right? Or if you explain to them what you were doing. So how do we use the things that we already have in place? And when it comes to things like clinical trials, I've been on a lot, I was officially on, and a lot as Mama Bear to much of the community, I've been really helping people with. And when you look at that and you come across a couple of those clinical trials where the trial works, the patient no longer has sickle cell, but the patient dies. So when you look at that, it is generally that support wasn't there. Maybe that caregiver came to sit with their patient, but they also brought 2 kids with them. Maybe they didn't realize that after you are quote unquote cured, there's a period of time where you still remain isolated, or that maybe that carpet that's been in that apartment you've been living in has fungal stuff, and that needs to be ripped up and handled before you come home, right? So, and then the other thing is that the care team that you get when you get with the transplant, they are there with you. I have seen them. I have cried with care teams when things went wrong. I've cried with them when they went well, but that care team is not going to be there when you're transferring back into the real world. So where is that support? Who that person that understands your entire journey, at least to help you transition into your new state of wellness. So I don't know if I answered the question, but that's kind of what lessons we've learned and how we're thinking going forward.
Thank you so much, Adrienne. And some of the advancements that we heard about with telehealth and some kind of innovative solutions could really be something that's, created as potential solutions that could be dispersed, via deliberate efforts and resourcing. So thank you for sharing your experience. And we're very grateful for everything you've done for the community, Adrienne. It is a very exciting time to see what will happen next with potential, potential early approvals. But that, you know, the thing is that we always say is that our current successes, even we have positive outcomes, are also our problem statement. They point out what we don't have to handle these successes. And that's what we, I think that creation of this infrastructure is going to be critical. So Jeff is standing. I think he is going to introduce the next panel. We hope this stimulates conversations throughout the conference. So thank you so much. Thank you to all the panelists.
Yeah, thanks so much for a great panel. And we'll, hopefully these will be recurring themes that we can continue to develop through the conversation. So we're going to do this. We're going to continue to the next panel, but we're also, we kind of suspected we might run a little bit long. So we're just going to go with informal lunch. It's out there. So if you're hungry, don't all rush up at once, but feel free, we'll call it a working lunch. We're going to not break for lunch. We're going to continue to the next panel, and then we'll see where we are with time. We'll probably have time for a short break, but we're going to cut into lunch and move forward with panel number 2. And do you have I had one slide, sorry. Making this so hard on you. And yeah, let's just go down. Should be 13, I think. Well, there we go. Okay, so I should get on the. That's it. Great, thanks so much. So again, this is just some highlights from the listening sessions. So we have a lot of innovative programs that were described and talked about in the listening sessions, and a lot of the representatives from the Alpha clinics and some of the Bridges students described, you know, activities, everything from formal training, more formal training programs, including nurse training, research coordinators, and pharmacy, to some of the work the Bridges students are doing around both community engagement, manufacturing. And what came out there is that a lot of these efforts are portable or could be reproduced in other areas. So that was viewed as an exciting resource. So in addition, outside of resources that CIRM has helped develop, there are a number of established community-based programs, particularly community health workers and community-based participatory research initiatives that have demonstrated effectiveness in the communities we're talking about, and raises the question, you know, could there be a regenerative medicine component, you know, built into that? So for example, in the case of community health workers, the idea is that if they knew more about sort of stem cells broadly, those questions come up. And we heard earlier about patients, you know, crossing the border. You know, often when you cross the border, you're someone's trying to pitch you on a stem cell cure for something, and we don't even know what those stem cells are. So there's opportunities really to engage and educate. In addition, medical societies and associations have programs that could be leveraged further. We've, you know, talked about some of the community oncologists that came up earlier. Again, are there opportunities to build capacities there? And I think one of the big takeaways is that we envision that these programs have to be time sensitive. There was overwhelming sort of sentiment in the room that people's time is really precious. These things no one's going to go for a 2-week something or other. It's got to be virtual. It's got to be in the evening. It needs to be potentially, you know, incentivized so people aren't losing work time to get this type of training. So with that as a backdrop, I'd like to, I think, Amy, do you have you are right behind me. I'm going to pass the mic.
Thank you, Jeff. Well, as an educator, this would be the time in my lecture where I would look around, know that I'm running a little bit over, and suggest that everyone at least stretch a little bit and wake up so that I could make sure that they could actively engage. But I have a feeling that unlike many of my lectures, what's going on right now is that we're all just so incredibly for me, I'm awestruck at all the opportunity, the potential, and the stories that we've heard. And I am so appreciative of all the work that everyone in this room has done, has catalyzed, and absolutely especially thankful and grateful for the patients who have volunteered their times, their lives, and their resources to really help us leverage what we have learned to move forward to really help our communities. And it's really, for me, an unprecedented time. My name is Amy Sproles, and I've served as the CIRM Bridges co-director since 2008, when the CIRM Bridges program first launched. And I'm from Cal Poly Humboldt. Since then, I am thrilled to have been able to continue that journey with Jan Nolta and her amazing team at the IRC, other collaborators across the state, and also to grow the community of people interested in promoting stem cell biology, regenerative medicine, and community outreach in our Humboldt County. And so one way that I've been able to do that is to transition into a role as more of an I guess, administrator for sure, but I really love my position because I'm still faculty, and I'm a faculty associate dean of academic programs, which means that I'm uniquely poised to help support students identify academic pathways that help them bridge their intellectual excitement with their personal motivations for coming to college in a way that they can really be confident that they're moving forward in creating a life that will make them and their families able to achieve what they think it would be to be their best selves. And for me, this is also important because I was one of those students, as we all were. And so I was a student at a small liberal arts school in Massachusetts in the early 90s, and I was really motivated to address social justice issues. And I changed my major focus about every other day until about my junior year, when I really started to get excited about the potential of biomedical science. And at that time, I couldn't have even articulated it the way I just did, but I was really excited about the opportunities that we could provide humanity through science. And so I did an undergraduate research experience at the UMass Medical Center, and that was really great. And I loved science. I will always remember my first signal transduction cascade lecture on the chalkboard with cyclic AMP from Dr. Joe Curtis, and he's the one that set me on my academic path. But that wasn't sufficient. And so I took a year off. I went to Genzyme. They were just starting their first rodent studies for their clinical trial for cystic fibrosis therapy. And I was going to be that histotech that changed the world. And that was great. I was a terrible histotech because I was kind of overwhelmed by so many things. I realized, I don't even know enough science to really engage. So I went to Vanderbilt. I joined the IGP graduate program to create biomedical scientists. I joined the team that was founded by Stan Cohen after he won the Nobel Prize, because we were going to cure cancer. And that was really exciting too. And so I was at Vanderbilt. It was wonderful. And that was great. But honestly, some of my most treasured experiences was going into the high schools and talking about HIV and AIDS and what that would mean. My PhD advisor moved to the UC Davis Cancer Center. I followed him here. And then just about that time, my husband, who also has a PhD in biochemistry, but got really motivated and inspired to address social justice issues in environmental justice, now we call it. He was recruited by 3 of the major Indian nations of Northern California to launch their campaign for dam removal on the Klamath. And so why not go there? So I picked up my young son. We moved to Humboldt County. I was really excited to go support my husband, support the tribal communities, but also to really engage with students at Humboldt State University. And fortunately, they let me come in and teach a molecular genetics lab. And now here I am a few years later. And so then the CIRM Bridges Initiative was introduced. And my mentor, Dr. Jacob Varkey, had been at Humboldt for a long time, really trying to bring in molecular biology, basic molecular biology training. And he had been extremely successful in that environment, which was really grounded in organismal biology. And so as we started thinking and trying to identify how to move forward, we reached out to the Humboldt Medical Society and Penny Figas, who I have a feeling was much more attuned to the fact that this could be game-changing than I was, because of course I was coming to bring science to Humboldt County. And it turns out science and cutting-edge medicine was really already there. And so we were connected very quickly to some of the outstanding physicians in our community. Dr. Joe Carroll, who is here today and has really been at the forefront of connecting our rural community to cutting-edge medicine for decades. Dr. Carolyn Connor, who's really grounded in bringing up the next generation of biomedical sciences, and Dr. Join Liu, who just joined us on the previous panel. And what they taught me was that even though we were in this extremely remote area in the state, 5 hours away from the closest medical center and probably the nearest cell culture hood, there were incredible people, brilliant, innovative people that had been in the community for a very long time and were creating facilities and clinics and support systems to make sure that our diverse community was well served and connected despite their rural barriers. And in our community, that meant not only people that were first generation, there's a lot of rural poverty, but we are actually centered in one of the most populous areas of the state that serves dozens, literally, of active, thriving, culturally grounded, place-based tribal communities. And that was a really big deal. And they're so place-based that I will just share in the middle of my slide. It's very busy, but you can see the HSU star. Each of those nations are on their ancestral lands. Those aren't county lines, those are ancestral territory lines. They have been there since time immemorial, and that is their place. So for students to leave their place, even to come to Humboldt State, is a big barrier. And that was important for me to know. And so we collaborated together. We launched our CIRM Bridges program. We did training at Humboldt. We collaborated with the Humboldt Medical Society, and then our students would go off for their year-long training program to be trained in all the cutting-edge science and therapies and help us move from bench to bedside. And they've done a great job under the incredible mentorship of our UC Davis partners, as well as Stanford Medicine, UCSF, and Gladstone. We also included very deliberately a portion at the end of the internship when they would all return to Humboldt County, interface with the clinicians, get a better understanding of what it means to be on the ground in a rural place that is underserved, and then also reach out to the high school students, work with physicians so that they could think a little bit about the various privileges, barriers, and of course, opportunities that rural communities provide. And so now here we are 15 years later, we've had 122 CIRM Bridges interns. Approximately 45% have been trained by Jan and her team here. About the other 25% at Stanford Medicine, and then 10% at UCSF. 89% have been retained in biomedical careers. Many were first-generation college students, low income. Only 30% were math ready when they came to college, meaning they had to take college preparatory courses to even take the first major requirement to be a biomedical scientist, and they're still successful. 48 have pursued additional degrees, and many are active in the field of cellular-based therapies. And so the other thing that the CIRM Bridges partnership has created for us is a network of community members that can be responsive to the needs, the medical needs, when they arise, even if it's unexpected. And so a wonderful example of that is when the COVID pandemic hit and the CLS professionals were first starting to get the information about the way in which you would be able to sample individuals in a community. And it was clear that the solutions we couldn't order from Fisher. And so we were actually able to partner with our local CLS groups. We had the Department of Public Health. We had our UIHS clinical team. And I'm pleased that lab manager Christy Madden is here, who literally built from the ground the Biohazard 3 testing facility and populated it with many Humboldt students who had benefited from the benefits of CIRM training. And then we created 1,200 kits one day in the lab on, I guess, March 17th, 18th, 19th. Bridget Blackman's there. You can see her. That's our CIRM training facility. We were able to repurpose it to create testing kits that got circulated all throughout our county. And so now I'm standing in this room after spending decades trying to figure out how I could help connect people to medical therapies. And it's just amazing that we're here. It's amazing all the work everyone has done and the real potential we have. We have a foundation in Humboldt, in one of the most rural places in the state, that can actually come together, continue to collaborate with the research centers to bring therapies to people. And in addition, we're in really an unprecedented place because Cal Poly Humboldt was recently designated by the governor to become the third Cal Poly of the system. So in addition to SLO, in addition to Pomona, we are to be the third. And we received almost $500 million to achieve this goal. Much of it is grounded in academic programming, and those programs are really going to be designed to serve the medical needs of our community. We have a bachelor's in health navigation coming online. We have a certificate in CLS coming online. We have a biotechnology certificate coming online. There's a $10 million healthcare training center that is a collaboration between Humboldt and the local community college. So we're poised and ready to learn from all of you and figure out how we can tailor the resources to be able to deliver those promises to our community. And it is so exciting. So thank you all very much for all your great work and for having me. And so without further distraction, I cannot wait to hear from the next panel because it's going to inform what we do at Humboldt. So this is the Workforce Development Panel, and it's really wonderful that it's being chaired by Dr. Kelly Shepard, my longtime program officer from CIRM Bridges. I believe we also have Dr. Daniela Bota, Dr. Denard Fobbs, Jennifer Peterson, a cell transplant specialist, and Elsa Butler is a clinical trials regulatory specialist joining us by Zoom. Panelists, if you wouldn't mind taking your seats over here, I think we can begin. And Kelly, do you want this? Oh, okay.
Hello? Yes. Good afternoon, everyone. Welcome to our session on workforce development. And that was a great presentation to get things kicked off from Dr. Sproles. Thank you very much. And the section was discussing a lot about the infrastructure challenges and potential opportunities related to our Alpha Care clinics and delivering ultimately solutions and regenerative medicine capabilities to our communities. This session is actually the other side of the same coin because infrastructure isn't just buildings and space and transportation. It's also people. It's human resources. We have people in the communities and we have people who are trying to deliver and we have people who are trying to innovate. And we need more of these people in more areas. And this is a session to discuss the potential opportunities and challenges related and how we can start to build on what we have existing and to build on the capabilities that we're going to need to make things a reality in the future. So we've already heard from Dr. Sproles. So I'm going to begin by introducing some of the other members of our panel. And perhaps as it passes to you, you could first introduce yourself so everyone knows where you are and where you're coming from. And then I would like to hear how your organization's education and training offerings that you currently have or are currently thinking of developing could support clinical capabilities for our communities, care centers of excellence in the future. I'd first like to hand the microphone to Jennifer Peterson.
Thank you for this opportunity. So my name is Jennifer Peterson. I am a nurse educator in hematology, stem cell transplant, and IEC therapy at City of Hope. And so I was fortunate to have the opportunity to participate in 2018 in an education opportunity that was provided at City of Hope with collaborating with many of the Alpha clinics in training nurses or providing information to nurses on their role in the delivery of cellular therapies. So now our next steps are looking at a train the trainer model for presenting content to nurses who are interested in cellular therapy delivery, and then how those nurses who would come to the program to be trained can take that information back to their home institutions and help disseminate the information to other nurses so that there is more knowledge and a greater understanding of the delivery of cellular therapies. So we are proposing a program in April of 2024, looking at the week of April 15th, open 2 days of the week, looking at possibly a 2-day program, and then supporting that program with ongoing education via modules, and then potentially nursing grand rounds where presentation of certain cases or complications or how different institutions and alpha clinics have mitigated or navigated through various patient situations. So definitely interested in collaborating with other alpha clinic centers if they are interested in developing content, presenting at the symposium education opportunity in April of 2024.
Hi, I'm Daniela Bota. I am a practicing neuro-oncologist, though right now I'm spending a lot of my time doing administration. I'm the director of the Alpha Clinic at UCI. I'm the PI of our Alpha Clinic grant, which has a very fun name. I'm going to show you later as of why. It is called UCI Real. And the reason for which we are called UCI Real is because we are our own micro network between UCI, our Children's Hospital of Orange County, our Long Beach VA, and our colleagues at UC Riverside, which are moving forward with bringing more cell and gene therapies to Riverside County, to our sister academic center. I had also the honor to be the Vice Dean for Clinical Research and in charge of our clinical trial portfolio for the last 5 years, and especially during COVID. And the people that are here, many of them involved in conducting clinical trials, know that that was the time on which we had a massive turnover in our clinical research personnel, at the same time at which junior physicians were asked to become investigators and co-investigators in high complexity trials, running them in enormously difficult conditions. And it has become apparent for many of us at that time that the training that people need might not be the training that they receive during their fellowships or residencies for physicians, and that the old model on which you learn by fire with somebody holding your hand, maybe a senior faculty to a junior faculty, it is not going to be appropriate if we want to introduce new therapies, and especially if we want to introduce them in multiple centers across the communities. But people are not going to take years out of their life to come and retrain. So what UCI is offering starting this fall, and it is on Zoom, and we are eager to have other people participating. It's a 20 hours after hours. Also, it can be done asynchronous on everybody's time while watching their children or, writing after they write their grants, not while writing their grants. And we are trying to get people to move through all the steps on what is to be a PI on a clinical trial. And then after we get that in the first half of the program, to get to teach people about the intricacies of running clinical trials in cell and gene therapies. For the most determined people, we also finish with a 2-week hands-on curriculum where people can come in our clinics and see how we consent, how we evaluate, how we monitor, and how we direct the treatment. The last but not the least, the second program, it's a combination of our efforts with Bridge and Compass students trying to create a diverse workforce on clinical research coordinators. As I said before, the turnover was about 50%. So we need new blood, we need new people. And it's going to be a boot camp done over the summer in a 2-month period, and which can be done by the students that are participating on other training opportunities.
Thank you, and thank everyone here. I am Dr. Denard Fobbs. I'm from Fresno, California. I'm a gynecologist. I am often stumbling to try to explain why I'm at the CIRM activities, and it goes back because this is not an obvious connection. Politically, the only politics I was involved in was being former president of the Golden State Medical Association, which is the state division of the National Medical Association. The reason that I'm probably here is that my wife, Pam, who's over on the side here, and I have been involved with CIRM since before it was actually CIRM at its conception. And for that reason, we've been constantly involved. And being from Fresno, we've been constantly interested and motivated and excited about the idea of Fresno becoming part of this movement and participating in it, benefiting from it, and contributing to it. And so I think what we've seen today is that that is happening finally. And we're very excited about that. We're happy about what we may have to offer to the global program from Fresno, and also what the program may help Fresno do in terms of further development. I think that having said that, I want to congratulate the CIRM family and the people who've spoken here, because it's been remarkable, enlightening, and it certainly testifies greatly to what has happened over the past many developmental years. I might add that some way, I'm not going to try to answer the question, but I think we have to communicate, and I've mentioned this to several folks in the CIRM office, better what's going on, what's being done, the kind of stories that we've heard today. We need to find some way to better communicate those things on an ongoing basis to the California population who pays for all this stuff. And also, when you talk about costs, since I mentioned the pay word, I think it's going to be interesting to take maybe a slightly different thought process about the cost. You know, we're dwelling here in California in the biggest portion of a $25 trillion American economy. So theoretically, we shouldn't have any cost issues. By way of example, a good friend of mine was visiting in Italy not too long ago, and had a chest pain and got a complete heart workup and a complete 4, 5, 6 days in the hospital and a stent. And while he was on vacation, and came back to America, and he never got a bill. So obviously there are folks that know how to do the money of medicine better than we do. And we should not have to reinvent the wheel. We should try to learn from some of those people. So I think that that's an example of what has already been spoken in part, which is that there are best practices that have to be recognized and should be recognized, and we should adopt to the greatest of our ability in order to make these things happen better and more efficiently. And also, there's been quite a bit of a commentary about the timeline, and I think CIRM has been great about establishing and holding to timelines very well, and I think that means that everybody has to do everything they need to do a whole lot more speedily and aggressively. So Fresno is well positioned. I'll just summarize as has been mentioned, because we have really great community multi-stationed hospital systems. We have the clinics. We have a great primary care network. We have a great university and city college network. And so Fresno's kind of been waiting and growing and developing beautifully over the past 10, 20 years for a time such as this, someone might say. And so I think that we're very, very ready, but also very eager to participate in benefiting from the knowledge and the practices of those who've gone a little bit ahead of us, and duplicating some of those things, and maybe where things haven't been quite worked out yet, helping to work things out to connect with the community so that we can contribute and establish this community connection and outreach, which seems to be always so difficult to do when it comes to clinical research. And so that's something that I think we're going to all discover together. I think that we should learn to keep it colorful and amazing, but simple. Because I'll use an example, when I had to, because I'm of a certain age, I had to renew my driver's license and get a real ID the other day. And in order to do that, going through, at my age, they have to make sure you're not blind, crippled, and crazy before they give you a new license. So I had to take the test, and all these things were done. And I realized that the technology now made it such that everything was highly demonstrable in a video way. Everything, all the testing was and learning was done that way. And it was done so that anybody of probably almost any educational level could easily accomplish it. So I think that we're going to really see how brilliant we are in terms of this scientific community when we start trying to articulate this to the people in the community. Because if you really know, I've always thought that if you really know what you're doing and what you're talking about, you should be able to make it really, really simple. And if you don't, it's going to be complicated. So we can't make it simple. Then we need to go back to the drawing board to find those people who know this stuff well enough to make it simple and communicate things to the community in such a way that they're enthusiastic, that they're enlightened, they're stimulated, and they support the clinical trials now, and they support voting for reestablishing and re-upping the financing for CIRM in a few years, and accomplish everything at the same time. Thanks.
Great. So thank you very much. So clearly learning to reach out and speak to a community is also a critically important skill that our workforce needs to be trained in at all levels. And I do want to mention that we do have one additional panelist who I believe is joining us by Zoom. Lisa Butler, are you able to hear us? And can you introduce yourself and tell us a little bit about what kind of education and training opportunities that could support clinical capabilities are available at your institution currently or are in the works?
Yeah, so my name is Elisa Butler. I'm a clinical research regulatory specialist at Stanford, but my education is actually in bioethics, and so I have kind of like a unique perspective about today's discussion. So yeah, I I'm from Stanford, and we have a couple of different options that we're trying to develop to, integrate into the alpha clinics, and then possibly, hopefully, also transfer to the community clinic model. So the first is a role called an access facilitator, which is still kind of in, while there's a job posting available, should anybody want to apply, it is a job that exists. It's still kind of like in flux of what the overall expectations will be. So it's supposed to be a little bit of community research based, but also like a helping profession when going into the communities and providing kind of like a liaison option to folks that are trying to work with, the Stanford institution. And then there's also an educational program that we're attempting to develop that is meant to eventually be scalable to be its own type of role. But right now it's the idea that we have is to have an asynchronous model for specialization in stem cell therapy, stem cell biology, for really anybody that is in an ecosystem of medicine or community health, where, you won't have the same barriers of access of education. So like, for example, we're starting to develop, like a curriculum that has things like the stem cell biology, current regulations around stem cells and treatments, clinical research history background, that you can learn online asynchronously at a low cost, provided by the education provided by like Stanford or Alpha Clinic professionals, to allow people that are already within, like the community health model to specialize in these aspects that are not currently available to, all levels of the medical hierarchy. So there's somebody was talking earlier about like access of patients and ability for patients to participate in their care, but there's also an aspect of, the people that are doing the work. There's also an element of access for that. So you'll notice that I'm not a doctor. I am not a PhD. I'm just, a reg specialist that also got to, talk about this. So I think that that's like a unique aspect that CIRM, I appreciate the opportunity to talk about this kind of stuff. So there's an intersection of, the hierarchy of medicine and how that, how we can impact that sort of gatekeeping that occurs also within, these educational programs. So I hope that made sense. But yeah, that's a nutshell, kind of where we are and who I am.
Thank you very much. So for some of these courses that are being developed, such as the Train the Trainer course that you mentioned, Jennifer, what kind of infrastructure capacity do you think is needed to help you to accelerate that program or to scale it or to make it available, if it's successful, as I expect it shall be, transportable and by other similar organizations around the state? Can you speak to that? Specifically, what kind of infrastructure might need to be built or resources that would be helpful for that?
So I think some of the advantages of being able to meet virtually and have modules that are available for individuals to review in order to enhance their knowledge, as well as having some type of central hub for conference attendees from different institutions where they could share information and support each other and possibly do complete group training. So it'd be a great place for patient and community education to occur as well.
So Dr. Bernard, Fobbs, I'll go to you next. So I guess I have a similar question for you. What kind of infrastructure or resources would you need at your organization in order to foster more partnerships with neighboring or even more geographically distant centers providing healthcare?
I think that I was actually mentally piggybacking on what you were saying about your program, because what seems clear to me is that we have institutions that have put together good training programs and good modules already. That's a perfect example of the kind of thing that shouldn't be duplicated again and again and again, wasting more and more time and resources. And I'm assuming there'll be a fantastic spirit of sharing and collaboration, so that the various different players throughout this network should be able to utilize that once again. And I think it ought to be a continuous refrain, that best practices thing. We already have a very well networked hospital physician system. The community in Fresno is a fairly well united and well connected community. So in terms of going from hospital to physicians' offices to the closely connected clinics to the neighborhoods, I think that we have the people, and we have the top tier, the leadership, and that having this information modules and information training systems that can be disseminated. I think that we're truly blessed to have the few things that were done forever usefully during COVID, which is getting us all on remote learning and remote contact, because there's just really no way now that we're going to have great difficulty in reaching out and touching the folks in the neighborhood and the communities and in the various groups that we need to touch because of that.
So it sounds like a sort of a centralized way that could be built to help make more of these connections apparent to people, because there are so many existing resources that have been developed, but they're not necessarily known in a widespread way. And so, as you said, not reinventing the wheel.
Yes, and I think we're gonna have to specialize in connectivity. We really have gone through a long period of disconnectivity with COVID. Zoom and digital communication has helped a lot. But now we will be able to use that in ways that we probably would have never dreamed of, 5 years ago, to make our connectivity, our reach, and our outreach a whole lot easier, broader, and safer at times.
Yeah. So Dr. Bota, you mentioned leveraging off of some of the existing workforce development programs that CIRM has supported through some of the regenerative medicine laboratories, including the Bridges program, such as mentioned by Dr. Sproles earlier, as well as the newer Compass program. And we have students coming in through these programs from the Cal State universities, community colleges, and some of the universities in and of themselves, which even though they are on the coast and localized right next to these cutting edge stem cell centers, not all of the students, even within those institutions, have had opportunities. And so these programs are great ways to bring in some of the students. I mentioned the Compass program because it's brand new, but also I think that's going to be a great opportunity because we're hoping to expose them to the different kind of pathways in which their skills are going to be able to make regenerative medicine solutions a reality for more people. And of all these programs, community engagement and outreach and exposure to the patient perspective is key. So I'm interested in hearing more about how you are going to involve those students and as a potential model for how others might do that. I'm especially excited to hear about your partnership with the Inland Empire and building the relationship between Irvine and that region.
So thank you for your question. UCI has a very long experience. It is named as, the first university for social mobility because majority of our students are first generation. A lot of our students are coming from underprivileged backgrounds. And our work was, the Cal State was the 3 years colleges was the high school students, all of them are building to the same goal. So going back to what I said before, adding more years of training, it's very hard. There is tuition associated with training. There's all this time on which income is delayed. And for people that are coming from a place where it's already difficult to pay for the college and to be in college, adding more time, it's not going to benefit us in the way of helping those young people find new careers. So the one which we interact with our campus students is that we are giving them the opportunity to complete the boot camp in the summer between their junior and senior year. So when they and keep the contacts during the senior year, so they can come back when they finish the senior year, not only with a degree, which might be in biology or computer science or whatever it is, but they have the interest on our work in cell and gene therapy. They participated on campus. Now they have the opportunity, if that's what their soul is, to go into a job as a clinical research coordinator that's already trained and that already has a certificate showing their ability. I'm going to just take 1 second to talk a little bit between remote and asynchronous models and Zoom models. And the other part, which it has become very apparent during COVID, which is we need people contact. And clinical research, it's a contact sport. You are there with the patient. You can learn just so much on Zoom. But then, in my opinion, each and every of those training programs have to be followed by some time in the actual clinic. And more important than asking what we miss and what we need mentors. We need our senior research coordinators and regulatory coordinators to continue to mentor our trainees when they go back in the communities where they might find themselves being one of the kind or two of the kinds. We need the physicians that we train for the community to be in charge of those clinical trials, to still have the connections with people in their field that have walked that way before. So that's a need that I think we're going to have to continue about how do we raise our next generation of mentors in this field and how we support them financially.
Yeah, thank you for bringing up the importance of mentors. Mentor training is also very key, isn't it? Yes. Dr. Sprouse, you're still on our panel, right? I wanted to ask you a little bit more about the large investment that the state is making to make a Polytechnic Institute from Humboldt, joining the two others around the state, both of which have had Bridges programs in the past, one currently. And I was very interested in hearing more about some of the new training offerings that are going to be developed as part of that you mentioned. And is that something that's being developed individually at Cal Poly Humboldt, or is this something that will be replicated at the other Cal Polys or even any of the other Cal universities around the state?
That's a really excellent question. So that I was also on the academic programs committee, and because in order to receive this award, we had to demonstrate that we were able to transition our academic programmings to be much more aligned with the other two Cal Polys. And though the majority of those programmatic needs fell into engineering, we also wanted to make sure that we still kept the heart of what those of us who had been at Humboldt State considered the heart of Humboldt, which was really grounding everything we did in community and even the liberal arts. And so because we also have the first Native American Studies program in the CSU, and we spend a lot of time talking about ways of knowing and traditional ecological knowledge, we started coining the phrase that Cal Poly Humboldt was going to be Polytech TEK as opposed to Poly TEC. And so that has really informed how we move forward. And so when I spoke of the programs a few moments ago, we're really working collaboratively across disciplines, across communities to ensure that what we design is going to give anyone access to those programs and then also allow them to benefit our community and others. In terms of whether or not they would be replicated at other Cal Polys, we haven't gotten to that phase yet, but we would be happy to join in those conversations, ideally in person and not over Zoom.
Okay, so I'm being told we need to wrap up in about 7 minutes. So Elisa, I'll ask you one more question, and then I think we'll open things up to the audience. Elisa, how would you envision that a partnership with community care centers of excellence would align with the ongoing or future initiatives of your programs?
Yeah, so the idea of the stem cell specialization really is meant to be a low bar of access to anybody that is within the field or within a hospital system to be able to develop this more specialized knowledge. So, you know, one of the things that we were thinking of was people that are, you know, either social workers or community health workers or folks that, or even, you know, medical assistants who are already in the system but maybe not, you know, in the higher levels of the hierarchy that typically get left out of these types of opportunities. So that those folks can also have an opportunity for advancement and education and specialization. It's kind of affecting a similar but different issue than the other folks are talking about. I don't know if that makes sense, but so it will allow a larger reach to understanding and knowledge acquisition to the further down parts of the hierarchy that can be throughout, you know, the whole institution.
All right, thank you very much. So we have about 5 minutes left. Are there any questions from our audience? Not seeing any questions. Do we have any questions from our panel? Okay, well, I guess everybody's hungry. So thank you very much.
Thanks so much for this opportunity. I really appreciate it.
Yeah, thank you. Thank you, Kelly. I think we did wear everyone out, but that was a sprint. So we'll take about a 20-minute break and pick things up about 1/4 after the hour. Thank you.
Yeah.
Okay, so we're on our third, let me just grab that for 1 second. On the third panel session, this really focuses on the access and engagement aspects. Again, sort of high-level notes from our listening session, 3 things to think about: trust, trust, trust. And it really put it in there because that was a theme that was amplified at every session in many different ways. I think the other aspects, and this, again, it's come out a little bit already in the panels, but when we talk about community or community engagement, we tend to, there's clearly a geographic component to that, but there was a big emphasis on these communities that exist in multiple dimensions, both in terms of online, culturally, professionally, and then a big one that came up with surprising frequency, and perhaps I shouldn't have been surprised, maybe I just haven't been out of town enough, is the sort of generational differences. And that gets into sort of youth and young professionals. That was, I think, particularly in the Valley communities. As I heard it, it's the notion that I think this it's a really important message for regenerative medicine being a sort of technical enterprise, or something that's new world, back to the Jean-Luc Picard, it's Star Trek-like technology. And a lot of discussion about the role of youth in terms of serving as translators or mediators of technology in a family setting. So that was, perhaps that's something that'll come up again on that panel. But I think, again, when you do these sessions, those are the little surprises that come up that you weren't aware of. Well, certainly I wasn't aware of. I think there was a lot of emphasis about trauma and its relationship to modern medicine, both the immediate experience of COVID and some of the historic experiences we know about research that was not conducted appropriately, and what that trauma represents on communities. And again, that's come up a bit already, but I think just to be really explicit, that aspect of pain did come out, and it is something that needs to be addressed, and perhaps it's the engagement aspect that's best equipped to address those sets of concerns. And again, the success ultimately will be dependent on partnerships, and I think we've heard a lot today already about sort of resources and partnerships, but no institution is going to sort of be able to do all this from whole cloth, that it's working together as a network. And that's something that I think we do very well at CIRM, is really help facilitate that networking. So with that, I want to invite Diana up. Diana has a very unique program because well, she'll tell you about it, but the neatest part about it is I learned about it through a CIRM, what we call a clinical advisory panel. So I was just super excited, because these panels are environments where we hear about our clinical trials and how they're going. And lo and behold, hearing about your program and trying to roll that into a CIRM clinical trial was just really exciting. So I will turn the mic over. Does that mean I'm on time?
Someone give me time. I can talk forever. Oh, yes. All right. Okay. Hi, can you hear me? Excellent. All right, so my name is Dr. Diana Naranjo, and I'm the clinical director and clinical psychologist and a professor of pediatrics at Stanford. And I run the niche program at Stanford. So the niche program is novel interventions for children's healthcare. And it was developed to really target, I would call it recidivism of avoidable hospitalizations. So a couple of psychologists in Oregon worked on a similar program with juvenile offenders and then realized, my goodness, I see the same thing in chronic health conditions where all of these social determinants of health are the things that are actually impacting kids' ability to stay out of the hospital. And so niche was developed about 10 years ago in Oregon at OHSU to reduce costs, improve health, improve care, reduce provider burnout, and reduce health disparities. And it's a tall order and a big ask, but we are so excited because 7 years ago, we rolled the program out at Stanford, and then 2 years ago at UCSF. And just this year, partnered with CIRM to bring this program to stem cell kidney transplant patients at Stanford. So how does this program work? It's wild. You guys are going to say, what? First of all, we believe that the youth and family are the center of care, and that all the things that surround the youth and family are the things that really drive health. And thus, we believe that the entire system should be turned on its head, and the care should be delivered where the children and families reside. So our niche program has interventionists that are assigned to families for about a year, and they go to the families' homes. They text and call and Zoom and FaceTime and all of the things to really try to structure families and get them in a place where they can access all of the health care things that they need. So we have strategic family and systems interventions where our interventionists are training families up on problem solving, on role stratification, on social support, things like driving them to the place that they need to go fill out forms for HHS, or driving them to Section 8 housing so that they can figure out how to handle or navigate that. Filling out forms for diabetes camp, which are like 30 pages long if you're trying to get a kid on scholarship, which is just wild. Then we also have this portion of their time that's spent liaising with healthcare teams and primary care providers. And these are not kids that are under-resourced in terms of things thrown at them. They're the kids that don't access the things thrown at them because the things thrown at them are really challenging and difficult to access. So they have case workers, they have usually social workers in various capacities, they have juvenile justice probation officers, they have school nurses, and yet they're no showing to appointments 80% of the time. They're not necessarily getting the public services that they would be entitled to. And it's really like the glue that connects it all together. And so we become the spider web, and we interact with all of those agencies as well as train families on how to interact with all of the agencies. And all the while we are constantly building up the relationship between children and the team members, constantly building up their, we don't want to come in, do everything for them, exit, and then everything falls apart. So all the way through, we're modeling, we are doing it alongside with them, we're watching them do it, let's call the insurance ourselves, and then, okay, let's call them with you. Okay, now we'll have you call them and we'll be silent in the background, and if you get stuck, you know that we're there. And we're available 24 hours a day, 7 days a week. So at any point, if there's a crisis, we're the first call instead of just showing up at the ER. So that's our very wild program. And we drive them places, we drive them to their clinic appointments, we go to Monterey or Fresno or wherever, and then come 4 hours back to Stanford. We incentivize them. So a kiddo with, I speak about diabetes because I work in endocrinology, but we see kids across the spectrum. We incentivize their blood sugar checks, and then we have families realize how they can incentivize blood sugar checks. And then we have doctors realize that the first thing out of their mouth when they come is not, oh my gosh, your A1C is 9.5, but oh my gosh, I saw that you did 2 blood sugar checks a day for the first time ever. That's awesome. So that they start incentivizing blood sugar checks, et cetera, et cetera. So what makes niche niche? We have a over 90% engagement rate with the hardest to reach families, with the families that really do historically no show 90% of the time. It's an evidence intervention model and really focuses on behavior change and targeting adherence in all of the different levels of care. and its intensity. Obviously, it's 24 hours and 7 days a week, accessing tech and interventionists with in-the-moment problem-solving help. But the real secret sauce to our program is the relationship building. And I think I'm on the next panel as well, and I'll speak a little bit about some of the challenges in building these relationships and some of the strategies that we've used that is different than other programs. Just a quick overview of who we serve at Stanford currently. It's largely BIPOC youth, and again, largely the ones that are the most frequent flying in our hospitals. And this was actually a couple years old, so you're not going to see any of the stem cell transplant kiddos on here, but we cover the gamut. I think we have sickle cell now. We have a few cancer patients. That cancer was not one that we were involved deeply in at first because they have a lot of services independently of, they're kind of siloed at Stanford, but now we've started to get that bridge. Okay, so a case example of just like a classic niche case. And this is not anything to do with CIRM, but just to give you a flavor of what we do. So imagine having a kid with a chronic illness. I think some of you in this room have a chronic illness yourself or have a kid with a chronic illness or care for kids with chronic illness. And so imagine that, you were just diagnosed with type 1 diabetes. All of a sudden you are having to think about everything that you put in your mouth or that your kid is having to put in their mouth, having to think about storing all of their new medical supplies, having to call insurance companies, having to take time out of work. You're a shift worker, so you don't get any time off. You have to measure blood sugar and make sure that the hands are clean, and then you have to dose insulin with an injection every time a child eats, right? The list goes on and on. Now imagine you live in your car, and imagine that's in Monterey. And imagine that was 2020 in the summer, that was the hottest on record. And so now imagine that every time you come to clinic, the kid's A1C is over 14%, and the clinic staff are saying, why aren't you giving insulin? And the mom's saying, I give insulin 5 times a day. And the clinic staff is saying, but that can't be possible. That just can't be possible. And so that's like where niche comes in. When we got this kiddo and went to their home, we realized, and nobody on staff knew, that they were living out of their car and they were keeping their insulin in a glove compartment box. And they didn't know that insulin goes bad if it's over, 70 degrees, I don't know, not 120 degree temperatures in a car. And so all of that was understanding contextually the things that were driving this kid's care and this kid's access. And just talking about equity and health equity, it's like so much missing the boat when you think about this kind of kid. And so we had to stabilize everything from, they actually ended up getting on a CGM and a pump, which at the time was really hard because Medicare would force kids to have a certain number of blood sugar checks per day. And if they didn't do that, they were non-compliant, and then they wouldn't get access to something that makes you do less blood sugar checks. So it makes no sense. But we got this kid to start doing 5 checks per day. We got everything pre-auth. We got everything automated and sent and delivered. But guess what? They don't deliver to a car. So we got it all delivered to the school. But guess what? Every month, even if you have automated delivery, you have to click a link in order to say that it got there, in order for them to release the next month, and they don't have any internet. And then the school blocked all internet except for school. So like every single thing was a place that most families, even well-resourced families, might just say, I don't know what to do here, and end up in the ER because her A1C or her blood sugars would, go over 400 because they didn't have any refills. And so by being there and understanding all of the complexities of the barriers, we were able to help them overcome each barrier. We partnered with a school nurse. The school nurse was gave her access to the nurse's laptop that was able to connect to the thing so that she could actually accept her deliveries every month. We got all of the stuff stored in the school refrigerator. We got them on Section 8 housing. We got them into a trailer. It was pretty incredible, but none of it was the typical thing that you would think of as a medical intervention. All of it were the things that made the medical interventions really challenging to do. So that's sort of a typical case. What about our partnership with CIRM? So this is new and we are still unfolding, but we at Stanford in the pediatric side, were approached and said, you guys have this program that might be able to help some of the challenges that we've been facing. And what if we partnered and just see if this is a good fit? So we have, and we had our first case. And what's interesting is that the first case is a pretty well-resourced family that has some financial access, a lot of health literacy and pretty high resource literacy. And they are a family that moved from somewhere in the Midwest for this study to Stanford. There is a stipend associated with it. But even so, even though they have what it takes, they were recruited and accepted and came, there was a lot of miscommunication between the team and this family and a lot of misunderstanding. And so this family has a 16-year-old that's in the study, a 13-year-old daughter, and a 3-year-old child. And they were like, who's going to watch the child if we have to be bedside and helping the 16-year-old with the thing? And who's going to watch the 13-year-old? We can't leave them alone and let them go to junior high, like in Indiana. And then, where are we going to live and stay? And so they ended up staying at the Ronald McDonald House. They got a room with one bed, and they brought grandma because they need someone to take care of the 3-year-old. And there was a lot of chatter from the two study teams, because obviously this is stem cell and kidney. So you've got multiple teams. They each have their own social workers. And people were wondering, why are they renting an Airbnb? Why are they blowing through their money this way? Don't they know that they're going to have to come back multiple times? Why are they bringing so many people? What, and us with our niche background, we're like, wait a minute, let us meet the family and understand what their situation is before we jump to conclusions or offer our own advice on how to handle these things. And once we realized how that was going, and even Ronald McDonald, you're not allowed to eat in your room. And then they were told, treat him like a toddler. He can't be around any other sick kids. And they'd go eat in the common area where there's all these sick kids. They're like, we can't do that. That doesn't make any sense. But study staff had no idea that that was a policy at Ronald McDonald. Study staff had no idea that they only had one bed. And so by us being able to get involved and help partner with them, we're bringing the things that are the reality and make it really challenging for them to participate in this study and for them to stay in this study. The team and them have already really broached a more, I think, understanding where each other were coming from instead of feeling like a push and pull between them. And also I think that our team is, and I don't know about your guys, yours might be way better than us, but it's very disjointed. And so you're really a part of two separate medical teams, and coming from an entirely separate medical system that you may have figured out is really challenging. And California is not an easy system to navigate either. So it's been really nice to have all of those pieces together. The next case that they're considering is one that I think would actually not even be considered for enrollment unless niche, if niche wasn't available. And it's a kiddo in Texas that's 20 or so years old, Black, no parents, and his 22-year-old brother is the donor. And neither of them have, I think, a high school education. Neither of them have high health literacy and barely any support at all. So I'm just not sure without the scaffolding that niche supply. I mean, I haven't sat down and asked, but they're considering all of these things and it's complex. But I think with the scaffolding that niche supplies, everybody feels more comfortable in allowing a more challenging and less resourced individual to actually participate in the trial and hopefully do it successfully. So that's sort of where our partnership is, and it's going to evolve as we grow and learn more. But in conclusion, I think that it's important to think about all of these beautiful programs that we run, all of this clinical research that we put together. There are so many more resources and amazing things available now than ever. And some of these families will never access them. And it's not because of a want of, trying or being open to it, but because of all the structural things that you guys have talked about today, it's just going to be out of reach. And so we need programs to also think about how to functionally make these things work and help families be successful instead of just here's another great program, and here's another great program, and families aren't accessing them at all.
Oh, let's bring Letitia up. Sorry. Let's bring Letitia up. Sorry. Out of order. You're next. Where'd Letitia go? There she is.
Hi, my name is Leticia Olvera from El Sol Neighborhood Educational Center. So I'm going to be talking a little bit about the Promotora model. As you can see in the picture right there, that's me. That's one of those ladies is me. And it is on 100 and maybe 15 degrees or 12 degrees weather. Of course, I protect myself, right? So I was covered from top to bottom. And that's the work that we do right there. If you can see, we do a lot of outreach door to door. And that's how we get the word out. And that's how we let the community know about our programs or any event that we have or any information that we need to release to them. In informational tables, door to door, as I said before, we also call them and basically that's what we wanted to highlight with these slides. Our work in the community, we have a beautiful program with close to home called Domestic Violence Prevention, and we are conducting surveys to see what they think about violence, and also we are creating songs, and we have a beautiful song that we created, or the group created, and video also. And I don't know if you have at the end, there's a QR code that you can check out the song and the video. That we have a saying that everybody has a role in this program in domestic violence prevention. Is everybody has a voice also. So that's something that we need to really consider in everything, not just in domestic violence prevention, but we are all responsible for whatever happened in our community. We all have a role, we all have a voice, and we need to everybody hear it, and those are the QR codes. So the first one is what is your role video, and the second one is domestic violence prevention song, if you want to check it out. And that's the community videos they develop by themselves, and our members for this program are people from the community. They are not working for any organization except us from El Sol, but they are from the community within the community. Thank you.
Good afternoon. I'm Zul Sarani, and I lead community outreach and engagement at Cedars-Sinai Cancer. And I work very closely with our cancer researchers to address disparities in our communities through research, outreach, policy, and practice change initiative. We also have an alpha clinic at Cedars-Sinai Cancer, and we're envisioning the possibilities of our partnership together. So I just wanted to very quickly share with you that, our catchment area is very racially and ethnically diverse in LA County. And these are the communities that experience a higher cancer burden. We also have higher limited English speaking households, foreign-born LGBT. We have close to 300,000 people in our catchment area who are LGBT. And high Latino populations, Asians, and amongst Asians, we have very high Filipino and Korean community members. And so our outreach team really represents this community. We have staff that represents every single, race and ethnicity within our catchment area. And we have close to 115 partners through which we implement cancer early detection programs, prevention programs. We work with FQHCs, community hospitals, and really the key thing here is that our staff has been engaged with the community to build trust, but also build capacity to do cancer control, and also capacity to implement research and work with us to increase awareness about clinical trials and participation in clinical trials as well. And we give out community grants close to $300,000 every year to our partners. And so we engage the community regularly in this bi-directional approach where we try to understand the needs from the community and then use that to really prioritize our work in research, outreach, and policy. One thing that keeps coming up in our community assessments is this general lack of awareness around clinical trials and the big need to reach multiple audiences with this topic and to figure out how to do this. And so we wanted to do something outside of the box. And so we worked with the Art Center College of Design and challenged them to develop materials and messages to create strong messaging materials and distribution systems to help community-based healthcare providers, health clinics, primary care physicians, advocates, leaders, to really spread the word on clinical trials, their importance in informing health outcomes, how and why patients should take part, build awareness in general, and encourage patients to ask their providers about clinical trials and drive patients towards existing websites, resources, and hotlines. And so they came up with 3 amazing campaigns, and I very quickly want to share them with you, just making sure I have enough time. So be part of the cure for your community was the first one. And really this came from listening to community leaders, community health workers, and navigators, and learning about their passion to help their communities and their motivation for justice. The campaign message builds upon the trust that people place in community leaders. And so these very leaders will be activated to deliver the message to the people. And you will also see, so these are some of the posters that came out, and they're in different languages, and we're still working on the translations, but the images and illustrations represent the diversity in our community as well. The campaign We Live in Out, there's also materials that feature real people who've participated in clinical trials and share their stories. And the campaign will live in outdoor spaces, in transportation, bus benches, billboards, and also on social media and digital media as well. And in addition to that, in addition to that, we'll provide a lot of promotional items and incentives that we can distribute in the community. The second campaign, which is called Diversity, and so in general, cancer patients have problems finding information and learning about trials. And providers are not comfortable explaining trials to patients. And so this campaign is really targeting providers to be bridges, to be information providers, and activating them and empowering them with information and materials and training. I think a big component of all of our campaigns is training to really spread the word and the message. And so, there's digital media, there's websites that we've created using we'll be creating using this campaign. But in addition to that, there's posters that we live in clinics and hospitals and in different languages as well. Here are some of the mock-ups. And one thing we also wanted to do is see how we can create demand for conversations around clinical trials. And so the idea behind this is to have buttons about clinical trials, and providers would be providing information to community members who ask about it and patients. And then there's one big component of this, which is an information booth that would sit in the lobby area with a kiosk and QR code to deliver more information for people who are waiting around. The last one is our trial, and our trial is really taps into the cancer support communities. There's so many different support groups that exist out there. And this whole campaign is warm, uses warm colors. The symbol is a hug. And the idea is to create social spaces within the community where people can come together that has a certain aesthetic and warmth, and is engaging to be able to provide information on clinical trials. It comprises of materials, an app which connects people to each other, and again, in different languages. It really can occur outside of a hospital. It doesn't have to be in a hospital. But really the idea is to create these warm spaces where people can come together, and we can provide promotional materials and items. But the campaign needs a lot more content inside, and training and methodology. And we have to think about every aspect of this. So I just wanted to share, these 3 campaigns, and, I look forward to hearing from folks to see how we can partner. Thank you.
So thanks everyone for being here today. My name is Maria Gonzalez Bonneville. I'm Vice Chair of the CIRM Governing Board. Patient engagement and outreach is really critical to providing access to the clinical trials we sponsor and the approved therapies that hopefully come from these clinical trials. And we need patient engagement in order to get these to the people of California. I was at a patient engagement conference last week, and there were a lot of strategies, and it was specifically for cell and gene therapy and rare indication. My colleague Abla Creasy was there, and my other colleague, Kern Temple Perry, was there as well. One thing that we took away from there is there was not a moment where anyone talked about reaching diverse communities or cultural sensitivities and how we address those, or even language barriers. They touched briefly on consent forms and how it was difficult for non-English speakers and readers to get through the consent form, and how they tended to drop out before they got very far because they just didn't understand what they were consenting to. So that obviously is a missed opportunity to be able to discuss ways which we can bring people together. I'm thrilled CIRM has brought us here together to talk about how we might be able to look at outreach and patient engagement. And so I wanted, I think, is Connie Stewart on? Yes. Connie, can you introduce yourself? And then also Bon can introduce himself, please.
Hi, I'm Connie Stewart, Executive Director of Initiatives for Cal Poly Humboldt, and the empty chair, I think, on this panel. My deepest apologies for not being in the room with you all, but I had 3 other health care related issues that came up, and if I had come, I would have only been able to take care of one of them, and being virtual, I could do all 4. So I run or have the honor of hosting a network called the North Coast Health Leadership Network up here in Humboldt County. It's Humboldt and Del Norte CEOs from all the health and healthcare and human service organizations that get together and talk about how we might improve the cost, quality, and access of healthcare in the region. I also work on healthcare workforce issues a lot, and I'm working on creating educational pathways to healthcare, helped restart the BSN, RN to BSN program at Cal Poly Humboldt. My ultimate goal in life is to get healthcare so good in our remote area and culturally sensitive enough in my health area that I can tell my parents who live in Florida to move to me instead of me moving to them. So it's very personal for me, this work. So thanks, I'll stop there.
My name is Vong Monatua. I am the Director of External Relations and Project Development for Community Health Systems in the Central Valley. And I participated in the listening session when CIRM came to our Cancer Institute. I'm also the mayor pro tem for the city of Clovis, and so served there. And I think when we were there, we were talking about outreach to sort of Southeast Asians or populations who don't typically come to receive services, Western medicine per se. And so we'll talk more when the questions come around. So that's who I am.
Thank you. So we've heard a lot about the challenges to healthcare and health-related outreach in your communities. And so I would love it if you could all just address that, what the challenges you've seen in the community, and then what's worked for you to try and bring people together in this context. Letitia, do you want to start?
Yep. Okay, my name again is Leticia Olvera Richard, and I think one of the barriers are the lack of transportation. And as many people mentioned before, the internet is a big issue too in our community. And I think another problem is the housing, affordable housing, because one of the barriers for our community or my community or everybody's community, because I'm starting thinking like we are all human beings and we just need to come together as a whole, as just one, no African American, no Mexican Americans, all Americans, because we are all here. So I think the affordable housing is one of the biggest barriers because both parents have to work full times in order to pay a house. The smallest house is $400,000. It's like almost $3,000 a month. So we need to work very hard and no time to go and get a physical, no time to take care of our kids. And therefore they are on the streets and doing God knows what. And I think also sometimes the community doesn't know what is the difference between the urgent care and emergency care. So we sometimes abuse of the emergency care.
Oh, so many barriers. Maybe I'll talk about barriers to research. Is this a good place for that? Okay, so so many barriers to research. At Stanford, our IRB forbade us, and I can't remember the number, it was 3 at some point, now it might be 5, contacts to families to offer a study. And in a 2021 article by Deborah Ellis, specifically in BIPOC recruitment efforts to participate in a clinical trial, they found that the mean number of contacts were 10.2 over 6 months. And that for the really hard to reach folks, it was 10 months and it was 15 outreaches. And so by the very nature of what our IRB had said we're allowed to do without harassing patients, excluded the BIPOC community. So we actually gave them that paper and said, listen, we need to be able to contact a little bit more than 3 times. Other barriers to participating in clinical research, I think we have some limitations on whether we're allowed to text or email, and some of the emails have to be encrypted. And that's just a whole nother level of click here and do this and do that people just don't do or can't do. Hours. And so the clinical research coordinators, mine always are Spanish speaking because that's our largest second population, but also always have flex hours because a lot of the families don't get home until 9 o'clock or on Sundays. And so we need to make sure that we're contacting families when they're available, as well as bringing the documents to families. And then the biggest, I think, is language, because we have so many languages, and actually somehow we got flagged as being able to handle languages. So we have many patients that have ASL that's not ASL, it's like SSL. So it's a translator and a translator for sign in other communities and other languages, which is incredibly challenging and makes like all of the documentation challenging, makes all of the follow-up surveys challenging. And that's just not even talking about health literacy or understanding or cultural beliefs, but we try to get through these by some systematic changes, like at the IRB level, and, you know, arguing about PHI and text messaging links as opposed to having to do these encrypted emails through my chart that our families don't even use. But those are our main challenges.
So we see tremendous disparities in the communities we serve, and I'll share a few examples. So in the LGBTQ plus community, this is a community that's a very large community within our catchment area, and they're invisible in the data. So we really don't know, you know, what's happening in terms of cancer with this community. In addition to that, they feel discriminated in the healthcare environment. And so some of the things we've started doing is, so we're located in West Hollywood, and we activated our leaders and, you know, folks within our cancer center and our medical enterprise to develop a model for gender affirming care. And finally, I think after 2.5 years, we have the Pride Clinic, the Pride LGBT Clinic, which is striving to, you know, create a model for folks in LA. And in addition to that, you know, we're using approaches that are gender neutral. So we realize cancer screening is gendered. You know, if you're a man, you do this. If you're a woman. And so we're developing guidelines and tools that are gender neutral, inclusive for this population. And we're going to be testing them pretty soon. It just turned out really wonderful with community engagement and input. So that's one example. The other one is, we work with a lot of immigrant communities. LA is about immigrants. And in the Korean community, we realized that despite the fact that, you know, we have My Health LA, which is universal healthcare in LA, a very large percentage of the Korean community was still uninsured. And so our goal was really to create, so we took the Promotora model and we adapted it for the Korean community because this has been so successful, and worked with trusted leaders like churches. There's like 300 churches, Korean churches in LA. And we worked with promotoras to really connect the dots for community members for healthcare access. So it was a lot of elaborate, you know, building bridges and connecting the dots for the community. But at the core of it all was the navigator. It was really the promotora that did it all. We just brought it all together. And that has enabled us to do research and start thinking about policy changes.
I think the barriers are all similar. But what I've seen in our community, you know, there's not enough of all of you, because all of you care so much. But how do you get your peers to care? That human element is missing. Because what happens is we can have a Sikh doctor that is high, brings a lot of business to the hospital, but when his wife passes away, the CEOs don't show up at the funeral. You know, the top doctors don't show up. So until you show up, you will always kind of have that chasm of trust or distrust. But when you go because it's not a medical appointment, when you show up because you care, then all your research, all that you're doing will work. And what also needs to happen is you need to bridge all the gaps of everything in that community, meaning go to the electeds, go to the CBOs, go to everything, and also require, we do it for high schoolers, require them to do community service, but your Hmong doctor doesn't show up at the Hmong events. You know, the Latino doctor doesn't show up at the Latino events, and then the head doctors don't show up. So in other words, I only know you because you're this highly doctor, and I come and I'm so afraid to talk to you. But when you show up at these little things, to them, it's great because you're so busy, but you made time. And I think that's how we need to work in our communities to build that trust and use the different individuals in the different ethnic groups to go out and to touch and share the same things with the communities. And I think it's difficult being on this, you guys, the CIRM board, being who you're going to support. I say look for the entities that really have anchors and roots down into every facet of the community. And, you know, medicine is nonpartisan, and so should local government be nonpartisan. And how can we then just cure and heal people together? I think that's what I see. I know I didn't answer it wholly, but that's what I feel, because I come here and I listen to all of you, and you know, these are all experts, and you're speaking things that go over my head. But at the same time, you care so much, and yet I don't feel it from your peers. You know, the peers that fill up the entire hospital. How do we feel it from them as well?
Thank you.
Can I just
Connie, yes, please.
Yeah, can I just add, you know what, one of the certain challenges, I think you guys all covered it, and I was really moved by the conversation about LGBTQ folks, because when I was on the board of a clinic, we did not realize that we needed a trans clinic even in our rural region. And it was only because we got a call from San Francisco screaming at us about how many people were coming down from our region that we went, wow, we didn't even know this was a need. And so that's one, you know, that's one of the major challenges for our regions, is making sure that we are paying attention to those needs. And then the other is just the wraparound services around, you know, when a person's coming in for a clinical trial, they maybe have other chronic illnesses. Are those being taken care of elsewhere? Do they have access to all those social service programs? How do we communicate, you know, so our communities are looking, you know, like at San Diego's model of how do you make sure that the caseworkers all know what's going on and that person's just as involved, what's happening there? How do we have everyone in this conversation in a HIPAA world, or a world where IRB doesn't understand the patient experience or something, in order to make sure that that patient is getting the right care? And then also, how do we catch the person early enough in their diagnosis when folks wait so long for primary care, and it may take so long to get them to know what their condition is and what their needs are in order to get them into a clinical trial.
Jeff, I hear some things that might go into a concept plan. So all, you know, different communities communicate in different ways. And we would love to hear sort of strategies that you guys have seen have worked in these various communities, but also what are programs that we can fund to help you all communicate with the people who need to come to these services?
Okay, I explained a little bit earlier, and what we do is a lot of outreach, and we recruit promotoras from that community that they trust. So the promotora model is we have flexibility, we are very empathetic, and we understand the needs in our community. Me, myself, when I came to USA, I was talking to somebody here. I started working at La Quinta Hotel. I was cleaning rooms. And then I went to the fields to work on the grapes and all that, but I last only 1 week because I couldn't. But I know what it's like to be working on those places that is really hard, especially in the valley where I come from. The degrees, the heat is tremendous, like 120 degrees during the summer, and we are working over there. So one of the communities that we are working right now is the Purepecha community. I'm sorry. And we have three promotoras from that community. So that's one way to outreach those communities. I'm so sorry. Getting people, promotoras that the community trust. But I need to clarify this. If we collaborate with any organization, CIRM or whoever, we need to know that is real. We need to know that is good for the community because we put our face over there. And me and the promotoras, we don't want that they come and tell us, oh, you promised me this and we're getting nothing. Because a lot of our organizations just come to us and we just go and do surveys and then nothing happens. So we have to have a goal, but we have to accomplish it, not just blah, blah, blah. We need to talk the talk and walk the walk. So I'm just telling you, because if you are thinking about El Sol organization, we need something real and something that is good for the community, or we are not doing the work.
For engagement, we have a lot of strategies. I'm going to switch my hat to niche as opposed to clinical studies in general, because at niche, it's a clinical program. And so we have flexibility and we have money to do random things. So when we're assigned a patient, it's usually coming from the care team, and usually the care team is very worried and really struggling. And there's a lot of provider burnout around these families. Oftentimes they don't answer our calls too, or they no-show to the appointments we set up as well. And we're trying to engage with them. We're trying to enroll them in our program, hopefully enroll them in our clinical research of the program as well. And so we do things like drive by their house and just randomly show up. We were in the neighborhood, or we will give them a raffle. You won the raffle this month. And so we have a gift card from Target that, gosh, we just wanted to give to you. Is there a good time to give it to you? We leave gift baskets on people's door with a little note, like, we're so excited to have you as a part of the program. We'd love to meet with you. Sometimes there's a lot of trust issues. And so we'll just meet at work, which is a McDonald's, at the time that is specific and able for somebody's break, 15-minute break. But we just try to be as flexible as possible, and then try to incentivize as much as possible so that they see that we're not just, trying to use them or like have them engage in something that they don't want to engage in, or that's not going to be helpful, and that it's different than the things that have been thrown at them continuously.
Thank you. So I presented 3 campaigns, and I want to say that we want to start having these conversations about clinical trials and research way before anybody develops cancer. This conversation has to start at the neighborhood level with promotoras, with FQHCs, with people in churches. Really, I shouldn't say nobody's talking about it, but I haven't seen very much conversation, and people who are trusted, have to deliver this message as well. And so I just want to say that we need that robust, transparent conversation, way before people develop the disease. And so the campaign is a campaign, but it requires the bones and, the training elements of it, the materials, the pipelines from the neighborhood to the clinic that we can create with, for example, navigators that can, work for the hospital and in the community, like, people that can bridge these gaps very easily. And at the end of it all, there's no substitute for trust. And so you really need people who represent the community doing this work, because I feel like, I think of Dong-Hee Kim. I give her a tribute because she's opened up all the doors for us in the Korean community. And we said that, we're not going to do research. We really want to give back first in education and build the capacity of the community and give this community grants. And now we're doing research, and it took us 4 years, but we're finally there. So I would say building upon, an infrastructure that's working, and then incorporating additional, elements of clinical trials and research into that.
Can I say one more thing? I forgot. Something that you could invest in that would cut across is something like a great translation service that all CIRM things could use, because it's always based on this hospital that we partner with in research, and then they sometimes disappear. And so if there was some HIPAA translation iPad thing that could be, I don't know what it is. It's got to be some weird tech, but that could help. that would really help a lot of the different sites be able to engage in communities that they wouldn't normally have.
Okay. So one other thing that Promotora model works on engagement is that we go where the community is. We're not in an office waiting for them to come from 9 to 5 or things like that. We are there. We're at the food banks, at churches, everywhere, because we know they are tired, working 8 hours on the fields. They get home. So I'm not expecting that after that, they are going to come to my office and get the research that I'm giving them. So I go and I knock on their doors and I give it to them. So that's very important. Like we are very flexible and we go where they are. Thank you.
What we have found in Fresno that works really well is to tell the patient stories of the different ethnic groups, but to do it professionally and to give sort of, really shine a spotlight in that language. So sometimes, when we do productions to different ethnic groups, we kind of undersell it. We don't put as much in the budget, or if we put an ad on Hmong radio, it's just something really simple. But if we spend as much as we would on a spot on ABC versus a spot on ethnic radio, I think it shows. And what we've also done is we've engaged those who are from those communities, the different communities, to give them a chance to give back, to teach philanthropy, and to have those names show up on a door, show up on a wall. So that way, when people come in, I recognize, Rodriguez, or I recognize, Singh, I recognize this, because we have not been intentional where we have large populations to give everybody an opportunity to give back, because that also shows, okay, more of my community is trusting enough that they are putting their hard-earned dollars into that place. And so that's something which we've done with our Cancer Institute, where we said, okay, we're going to target 10 Hmong families and name 10 rooms. And we went to the Sikh community and go, we're going to name 10 Sikh exam rooms as well. Now we're going to name this elevator bay. We're going to name this waiting room. And so it makes it where people walk in and go, oh, these are names I'm not familiar with, but yet they are such a big part of our community. And then those people are now our champions to tell about, I trust enough that I come here to get services here. So that's what's worked. And you asked about earlier about the barriers. I think that the simple thing is there's not enough outreach. That's it. And it's not a barrier. It's a money issue where you only have X amount of dollars to outreach. And so you're spending it on where there is the greatest return. But if you can help us and say, these dollars, we want you to outreach to these communities specifically, that would be helpful.
That's what we want to do. So thank you. And Connie?
Oh, yeah. Can I just add, I think that, one thing in our remote community is we have collective groups that come together. There's 5 or 6 that are already working on issues that are similar. When you come, and we hope you come, don't create a working group around this project only. That's always a lost opportunity. There are plenty of groups that can merge you in and still give you actually even clearer focus. Occasionally we have projects that insist on they have their own working groups. And I will have this crazy thing where I literally will see the same people in the room at 4 meetings in the same day because the funder didn't create it in a way which we could all just say, we'd sit down, if you go to lunch for an hour, if this isn't part of your day, and come on back for the next topic or something. So I think, on the ground, we have we have really tight networks here. I have the CEOs of every hospital on my phone, and can call them at any time. I have the mayors and the city council members for every one of our elected communities. Was just talking to a supervisor before I got on this call. So we're really interconnected here already. And if you just give us the tasks you want us to help with, we can accomplish them.
Thank you so much. And I want to thank our panel. So I appreciate your time and all of your insight. So thanks.
Jeff, is Barbara in the back of the room? I just had a thought that I wanted to share based on that last panel, which I thought was just fantastic. So at Alliance for Cancer Gene Therapy, I'm working with the research community within the academic centers. That's what we fund, is academic and clinical research. That research community is incredibly diverse. It's really diverse, and a lot of the young researchers are from the same immigrant communities that we've been talking about as the patient community. And I'm just thinking, like, if we can bring those researchers who, I've heard the most passionate commitment from, closer to and more connected with what we're kind of calling the patient community, it's all the same community. And if they're sharing between, the patient experience and those stories and the researcher experience and the stories, I think making those people closer in what they do and what they experience could go a long way to connecting all of us.
Yeah, I think a big theme in this program will be sort of drawing on what is there I think that's a huge element of it. So I think we need to find a way to give visibility to, so we'll follow up with you in terms of some of these groups, but we'll give visibility to that. Let me, hang on, I just want to, so we do have time for some discussion at the end, and I'm hoping to protect that time a little bit. So I just want to get through, we have three, what I hope we can do is fairly quickly, which are we're going to take a break from panels and just have some of our colleagues talk about some resources that are existing that probably have potential to sort of tie into the development of these programs. So we want to go through those very quickly. We'll get to our last panel, and then we'll have some time for some additional discussion like we're just having now. So the point is we're on the home stretch. So I'll stop talking, but the aim of the next few talks are just to point you all to resources. If we can, any time you can shave would be terrific, because I think people are interested in some dialogue. That's my problem.
Okay, so as a physician scientist, I'm just going to go through our approach, UC Davis, our Apple Clinic, of how we can bring these things to the more remote areas, and how we can do these cell therapies, let's just say, in the corners of our state. Oh, they're moving. So our mission, the Apple Clinic, our mission at UC Davis is the same as the mission of the CIRM, which is basically bringing these to a diverse California and world. there are many challenges of doing this in remote areas. And I'm not going to go through this, but from the patient side to provider side to manufacturing side, the biggest size, everybody talk about that cost. This is the cost of a CAR T cells right now. If you want to do a CAR T cells, the price is about $400,000, but there's, you have to administer that in patients, potential complications. So the cost is going to get to like $1 million for a patient. When you get to sickle cell, it's just unbelievable. Just say you have 7,000 sickle cell in California. I'm stretching. We're not going to try to transplant all of those with this gene therapy, but just if you just want to use that model there, $14 billion. That's just a budget for just like a third of a budget for the whole California health system in 1 year. Multiply that with 7,000 diseases, genetic diseases. Where are we going to go from here? It's just impossible. This is the projection for the health industry for the CAR T cells, but I really think that's the tip of iceberg. Why? Because just look at the solid tumors now. Everybody says CAR T cells are way in the future for solid tumor. That's not correct. Look at the data. This is the panel on the left. This is CAR T cells for using a CAR T cell combination of CAR T cells with the vaccine. And with the CAR T cell alone, 33% response rate, mostly in germ cell tumors and ovarian. With the vaccine, the combination, 75% response rate. That's huge. When we look at the other CAR T cells for solid tumors, that was the mesothelin CAR T cells. Again, 13% only CR, but a lot of people maintain that. And this is just a start. We know it's working. We just have to optimize that. So just a proof of principle that's working there. Another article using this GD2 CAR T cells for the neuroblastoma, 63% response rate. That's very, very good start. And just imagine if just one of these CAR T cells be approved for, let's just say, lung cancer or breast cancer. There is no way we can handle this with the current system. There's no way. It's going to absolutely bankrupt the system immediately. How are we going to handle this? And the CAR T cells is not only for the cancer. Now we're getting to all the other targets as well. Fibrosis, using CAR T cells against the fibrotic markers, autoimmune disorders. We have 3 protocols already here at UC Davis for autoimmune disorders for the CAR T cells. And the story goes on and on. People talking about using CAR T cells for senescence, for aging, or for we are using CAR T cells, for example, for HIV. So there's so many options there. And again, there is no way we can handle that. Another challenge is manufacturing. Again, if these things comes to a market in a really large numbers there is no way industry can handle that as well. And that's why we don't think the traditional model for the pharma is going to work here. And we have to be creative. Why cannot we do that? This is an example that the traditional model for pharma is not working because, these things work like a gangbuster and then everything, it's just a bad memory. Everything fell apart. Similar to that, this was February 23rd or something. All of a sudden, 3 companies were working on sickle cell. They announced that they're not going to continue for one reason or another one. It just showed the challenges of relying on industry to do these things for us. And at the end of the day, as a physician, I have to move forward. I have to do something about that. I have to find a way to get these patients treated. The other challenges are geographic locations. Beside those few dots there, that we have better access. The rest of California, we don't have as much access there. Lack of infrastructure for the research. Many of these areas we're looking at, in Redding and Eureka and other places, they just don't have absolutely no infrastructure for research there. They don't have many of these trials. They need apheresis. They don't have apheresis in many of these places there. They need trained personnel to give these cells. They don't have that, and so on and so on. So geographic problems are there and needs to be addressed there. And we'll talk about that. So how is our approach there? We are, again, as a physician scientist, we're trying to use that, improve the science here and try to make this happens there. One of the things is, right now, CAR T cells are a big deal. They don't want to do it in a community because they're afraid of side effects there. There's causing too much of cytokine storm, neurological toxicity. How do you want to deal with that? There's a REMS program, all of those. Can we change that? And we are working on that. Better vectors. We don't need those side effects for the effect there. So by improving those side effects there, we can really address that. And again, there's a lot of research there. Some of the new construct we're working on has much less side effect there. And if there is much less side effect there, we're going to start internally there. They can sit in a hotel, get their treatments there, and they don't even have to come to the hospital. So it makes it then practical to do it anywhere, not necessarily at UCSF, Stanford, or UC Davis there. So again, changing the science can help with making it much easier and more accessible there. The other part is the manufacturing. So manufacturing right now, we have a centralized model there. You just do it in one area, and then you have to get the cells, ship it back to those areas. Limitations on manufacturing is a big deal there. Can we do it locally and everywhere? And that's again the model we're working on. What's the benefits there? Local manufacturing is cheaper. We don't have the overhead for industry there. We have faster time to the patients there. That improve outcome. Ability to give fresh cells, that improve outcome, and improve coordination of patient care, that improve outcomes there. So there's many benefits of doing local manufacturing, and that's what we start trying to do. For some of the rare diseases, it doesn't make sense. If you have a disease that's 1 in a million, it doesn't make sense to manufacture locally there. But and it can be, we have to move the patients there. But for many diseases, especially again, if these things comes to a much bigger market, lung cancer, breast cancer, pancreatic cancer, or autoimmune disorders there, then local manufacturing makes a lot more sense there. And that's why we're working with some of these companies there, and we already have contact with some of them and working with other ones. We're trying to bring those mobile units there to local areas, and we're going to start doing that for at least in 2 or 3 different places to just show the comparability that we can do this before we spread it to other places there. The other part is again automation. So right now you have the GMP is just a big deal, and building GMP is very expensive. The models most of them are not automated there. So if you have closed system automations, then you don't need GMP. You can do it in in just a clean room. In any hospital clean room, you can do that if it's fully automated and closed there. So again, working with these systems there that are cheaper at the same time automated will be really helpful there. We are working on at least a couple of them, trying to get out of the monopoly right now that's on the market there with just a 1 or 2 company, and trying to again make it more accessible and more useful there. The other part is changing the process. Again, I mentioned many of our places, they don't have apheresis unit. If you want to do it in Eureka, for example, they don't have apheresis unit. They can't collect the cells there. So can we use peripheral blood? Again, we're working on, both with companies and internally, we're looking at, can we just draw these cells, whether it's stem cells or mostly CAR T cells, can we draw these cells from a peripheral blood? So it can be done anywhere. It doesn't have to be in a major center there. And then enhancing the whole process. Again, coming out of that monopoly that we have, we just sent a grant, for example, for this, trying to do the selections in a much cheaper, much more efficient way there, trying to enhance our vector, trying to improve our transductions there, using much less titer of vectors, that much less dose of the vector that makes it much cheaper, and so on and so on. There's so many things we can do in this process to make a process that's right now $400,000 down to bring it down to just say $40,000, $50,000 or even lower. We were just talking about with NIH about we want to do this, for example, in Vietnam at a cost of like $8,000 to $10,000. Can we do that or not? And we are working on the science to do that. And this is just what we call the California CAR T cells there. That's just one of our startups there that we're gonna just show that the feasibility that we can do these things not only at UC Davis but also in community centers there. So we are working with some communities to extend this protocol and do it locally there, and then learn a lot about that. And learning means there's a lot of challenge here, establishing chain of custody. So make sure we can do that, not only with a big center there, but also with community centers there. communication with tertiary centers there. We have to have a good line of communication with that centers, with community, between a community and tertiary centers there to be able to do, again, manage this. And if there is a complication, we should be able to bring that patient and have a bed here to do that. So all of those things, it's just this is our sort of a first trial to see if it's feasible. We can do these things in a community center there. In the long term, again, we're looking for local manufacturing. So that will be the next step there, hopefully in a year or two, that we want to move these units locally there to the community and then establish this the same products we're making exactly look like the same at UC Davis and be able to use that and that. Identifying and training staff is obviously critical there that can do it locally there. So that would be one of the challenges there. And then establishing contingency plans there. That's, again, another big challenge is we have to deal with that. What about things goes wrong, how we can deal with that, and so on and so forth there. The other directions is, again, getting healthcare, health insurance payers involved, because I think that's a really untapped area for us. So we are working with, at least one company now, and would like to get more engaged with Medicare, Medi-Cal, with the Blues and everybody else, all the big payers there. So this is one of the companies we have been working on. We have, created some sort of a MOU here that we have to agree with that. And eventually, again, the idea is that they invest in research because usually health insurance, they are not interested in research. They're interested in just practice. But I think those are the one actually, they should be mostly invested in research. I'm trying to get them back to this kind of research activities. It's going to benefit both of them because at the end of the day, everybody's benefit is in cutting the cost and making it available. So insurance companies should be very, very much engaged in that as well. And we are also working with FDA. Again, the problem right now is that who's going to pay for this manufacturing? If there's so many of them, CIRM is going to go bankrupt. The state of California is going to go bankrupt if you want to pay for all of these things down the road there. So we are asking FDA that if it's a clinical trial, can we ask the payers to pay for the manufacturing at cost? And I'm pleased to announce that we got our first approval there for our California CAR T cells. So the FDA agree with us that with basically no profit, basically we just at the cost of manufacturing, we can charge those to insurance companies there, and we are in the process of discussing with them. For us, that's a huge deal because then that will open up a lot of door for us. We can manufacture a lot of products there at cost, charge it to insurance companies, and the patient can use that basically, with no additional string to that. And the last thing is that, do we need BLA? Do we need to take these products all the way to commercialization, or can we just use them with the same method there? Because if there are 7,000, let's just say, rare diseases here, how are we going to do 7,000 BLA? Who's going to pay for that? It's impossible. But if we have just expanded access, and if we have a way to do that, we can just have a process ready and just switch the products there and only charge for manufacturing and not charge for any additional benefit there, but make it accessible for everybody for even the most rare diseases there. So again, that's a discussion. We're working on FDA on that. And the last part, again, engaging the state of California because they already have a mechanism there. They already paid for insulin, for example, at cost there. And they're asking the state to engage in those discussions there because at the end of the day, again, benefiting everybody there. So that was my short discussion. Sure.
Making Sean get a lot of exercise getting up and down. So we're going to hear from the telemedicine program next. Yeah. And again, Mehrdad, I guess everyone can just email you to, get on board with you'll send the tractor trailer up and it'll just park it outside the medical center, right? Excellent. Yeah.
Thank you.
Thank you.
Hi, My name is Aaron Ulmer. I work at Center for Health and Technology here at UC Davis. We just wanted to talk really quickly about utilizing telehealth in clinical trials. And I think really we're kind of going to try to roll through this. So I think we just kind of want to talk maybe about how we're using it here at UC Davis, and then you can always reach out to us if you have any questions about implementing that. So at UC Davis, we are doing a variety of different kinds of telehealth. We're currently doing MyChart video visits for our own UC Davis patients that are scheduled in our Epic system. And then we are also doing video visits through Zoom, connecting to patients in rural parts of California. We work with a variety of inpatient hospitals and outpatient rural health clinics. And we provide live video visits through Zoom, and we also do e-consults. It's traditionally store and forward consultations where we review images that have been sent to us. And some of the benefits is basically this helps save our patients a lot of travel time. There's it just really is a way for us to be able to get specialty care out to rural areas, rural parts of California. We do primarily work within the state of California just for licensing issues, but we do some consults outside. We have some contracts that go outside of the state of California. And I think we could want to mention about just kind of developing the way you develop your workflow. We've tried to keep it consistent with how we would normally schedule a clinic with a face-to-face patient, so that we're not reinventing the wheel each time. And the video platform, I think a lot of what we do is through Zoom. To the rural hospitals, we can bring in the primary care doctor to the visit as we're talking to the patient. On our end, we can do education. We can have medical students and residents observe, and it's good to have tech support available and contingency plans. And I'm going to hand it over to Leah Meisel. She's on our DEI team.
Hi, everyone. Good afternoon. I'm just going to run through a few things really quickly that we are doing at UC Davis Health to make our telehealth programs more equitable and accessible to our traditionally underserved community members. So first off, just want to mention a lot of our digital health equity initiatives are very multidisciplinary. We have people from teams all over the health system working on digital equity. Some of them are working together, some of us are working separately. But basically our mission in regards to digital health equity is to facilitate quality improvement initiatives to promote equitable access to and benefit from telehealth service lines for UC Davis Health patients. And then this image on the right is just our strategic pillars for UC Davis Health. So specifically, we are trying to advance health equity and address disparities. So this is a quick list of just a few digital health equity initiatives that are happening within the UCD system. So we have some folks doing research on implicit bias in clinical services, some folks working on collaborations with FQHC, specifically in a test to treat manner. Myself and many others are working on our telehealth DEI dashboard, which I'll show you a little snapshot of in a minute. And then we have a lot of different research projects working on a whole bunch of different health equity initiatives. Myself and Dr. Jennifer Rosenthal, who is a pediatric hospitalist here, we're working on conducting focus groups with community members with limited English proficiency to help us learn about their experiences with telehealth. So moving forward, just want to show you a quick snapshot of our DEI dashboard. This is going to go live in probably a couple of weeks, but it's a really exciting new resource that we have here at UC Davis, or we will have here at UC Davis Health. And it is a telehealth specific, user-friendly and live data dashboard, which will allow folks to see all of our telehealth eligible appointments, and see the data on basically how they're doing, how they're reaching our underserved communities. You're able to not only look at this overall view of the dashboard, but you're also able to see all of the data categorized by gender, age, language, race and ethnicity, insurance, California Healthy Places, and California Healthy Places Index. And you can also see different divisions, clinics, departments, specialties, and providers. And it's a great way to, our goal with this is to basically use this data that we see to identify where some of our gaps in our telehealth services are occurring, and then use quality improvement initiatives to try to make changes to some of the clinical services and the telehealth services that we're doing so we can better reach our underserved communities.
Terrific. Okay, I won't go back to my slides, but so if you remember early on in the talk, there was kind of that circle of the sort of some of the CIRM programs, and it included our clinical trials, included the Alpha Clinics Network as a second piece, community care centers of excellence forthcoming as a third piece, and the fourth piece is our patient support program, which is currently open. And Sean, you give us a little background on that program, because it's something that would clearly link up to a community care center, be part of that support network.
Certainly. Thank you, Jeff. Yeah, for many of those I haven't met, my name is Sean Turbyville, and built the medical affairs organization for CIRM. And really grateful to be here and learn about the capacities and infrastructure with respect to community care centers of excellence. This is a very important initiative and will have significant impact for patients out in the rural communities and the healthcare providers. A little bit of a funny story. When I was first brought on board, and Jeff and I were the only ones in medical affairs, we were presented this project, and we had about 3 pages of a PDF describing the concept plan, or at least the concept and what we wanted to do. And I turned to Jeff and said, well, this looks like a slam dunk. I mean, really all we need to do is go out there and put the centers of excellence out there with the clinical capacities out in the rural communities, and we're done, right? And then Jeff turned to the second page, and then I realized it's far more complicated than that. And so I've been really humbled, to be honest with you, thinking through all of the channels, interactions that I would have never thought about in putting one of these things together. So this is a really great opportunity. And I do want to thank Jeff Lomax and Emily for their leadership in putting these together. This is a phenomenal organization, and really look forward to seeing this to be a success. So as Jeff mentioned, I'm going to move on to another really important project. And good. So I think we're moving on to, as I mentioned, another important project that was kicked off. And of course, this is the patient support program. And I think it's fair to say that gene-edited trials are becoming more demanding on patients and require additional logistical and financial support beyond just routine costs that are traditionally with non-gene therapy trials. And there's been a big push for patient support programs, and then they have grown. They've become highly successful operations that now place greater emphasis on providing services to patients, and not just on the post-marketing side, that is taking patients from the clinical over to marketing. But more importantly, now you're starting to see a shift of the patient support services early on the clinical trial journey. And what Jeff and I and others have found within the last year, there's a number of service providers that have popped up. These are for-profit as well as nonprofit organizations that address the financial and logistical bottlenecks associated with gene therapy and gene-edited trials. And we heard from earlier speakers today talking about some of the logistical challenges, right? The informational challenges, et cetera. So this is a slide that just summarizes the barriers that must be overcome to achieve broad equitable access to regenerative medicine and clinical trials. And we did a lot of due diligence looking at the literature in terms of what the impact factors are with respect to rate limiting steps for patients enrolling in some of these trials. And this is by no means a thorough review of the literature. There's a lot more that we could put here, but you can basically summarize this into 5 categories. And the first is that there are certainly cultural and social determinants that have a significant impact on patients participating in clinical trials. We also know that, as we heard earlier today, information is critical, right? So not only information for patients, but also information for clinicians, particularly when you're thinking about the new trials, the new therapies that are right around the corner. What do we have? Close to 30 trials, 30 approved cell and gene therapies currently in the United States. And the FDA is expecting a minimum of 10 to 22 approvals a year moving forward. The other is the logistical, and we hear this all the time from patients. We hear this from family members. That is certainly a large rate limiting step for patients who are trying to participate in clinical trials. The other is financial. This is true also not only for patients, but also their family members. And the other is the ability base. That is, there's participation is limited for the elderly, for the young, for the disabled, et cetera. So we did a lot of due diligence and presented to what is referred to as our Access and Affordability Working Group. We probably spent a good 6-7 months presenting to them on different ideas on where the patient support program could have a significant impact. And we did get the opportunity to go to the board. And on September 20th of 2022, the CIRM board did approve the patient support program with emphasis, of course, focusing on helping underserved patient populations. More specifically, they wanted us to focus on 3 areas. One is the informational, which we talked about earlier, the logistical, and the financial. Now, this is not a large program by any means from a financial standpoint, but it does provide some resources to patients who are struggling to keep up on the financial side with clinical trials. So the objective of the patient support program is the following. It's to establish a statewide patient support program that provides navigational, logistical, and financial support for patients being evaluated or enrolled in CIRM-supported clinical trials. And this access will be, 1, efficient. So efficiency is absolutely key when it comes to information about a trial, right? Second is reliable, making sure that we have reliability. That is, that there's not a differentiation in terms of the type of information we're giving to one patient support, or to the healthcare provider. Making sure the information is consistent, and more importantly, thinking about much more robust programs that's being integrated, for example, with the community care centers of excellence here, or perhaps collaborating with, of course, the Alpha clinics. So we're thinking small right now, but we're setting up a baseline that actually is scalable for other components, other services that can be provided to patients through the support program. So as Jeff mentioned, we now have an RFA, and that is posted. That is a request for application. And the program is structured into 4 main services, and not to be redundant. First is the patient intake and navigation. The second is the assessment of patient family financial eligibility. This is important because anytime you are providing financial support for a patient contributing or participating in a clinical trial, there are regulations around that, and you want to make sure you're compliant. The other is reimbursement of eligible expenses. And finally, the fourth is more of an operational characteristic, and that is making sure that the coordination with CIRM and the sponsor to avoid any duplication of permitted reimbursements. So let's take patient intake and assistance. So with respect to patient intake and navigation, we want to be able to provide a robust service that provides support to inquiries about CIRM-funded trials. I think right now we're at about 92 trials out there. That's a lot of information for patients to scour through. So if there's a service that can provide that quickly, not only to the healthcare providers, but to patients, that is a win-win. The other is to make sure we can direct patients, when asked, to appropriate CIRM-funded clinical trials based on trial criteria, eligibility for appropriate determination, and potential selections. And so generally how this works very fast. Many of you probably work with patient support services. This is a quick warm transfer to this site, getting the patient or perhaps the patient's family member in contact with that clinical coordinator, and then that discussion takes place. The other is to manage referrals from CIRM-funded programs and clinical sites. So we didn't just restrict this to the Alpha clinics. It's expanded to community physicians, again, community care centers of excellence, community organizations, and other healthcare and provider entities. So it's much more robust than actually just peer-to-peer within the Alpha clinics. With respect to assessing patient family eligibility, so the patient support program will work with the sponsor and the clinical trial sites to evaluate the patient family eligibility and need for financial support for permitted reimbursement, services or products associated with CIRM-funded trials, and directing reimbursement based on financial criteria. The other is providing reimbursement for those eligible expenses. So we want to have the capabilities, the capacity to quickly administer the distribution of payments from the Patient Assistance Fund, a fund dedicated to offsetting the cost for patients deemed eligible for support. And speed is important here. There are a number of different service providers that actually take weeks in order to provide a reimbursement. There are other service providers that have pretty sophisticated infrastructure that can get reimbursement almost real time to patients. And the patients are reimbursed for costs, including but not limited to additional costs associated with travel, child care support, meals, and other costs associated with participating in CIRM-funded clinical trials. And this just gives you a snapshot of what we were targeting. So we're targeting additional travel expenses. We heard earlier today about the ask of patients to stay longer for, let's say, in a CAR-T infusion. There could be perhaps even as long as a week staying at that center of excellence. We're looking at hotel accommodations, meals, additional childcare, out-of-pocket healthcare expenses, other additional ancillary healthcare expenses, and other study participation costs. It's interesting, when you look at the literature, it's estimated right now that patients with respect to out-of-patient pocket expenses are spending about 8 to 10 times more than they would outside of a traditional gene therapy trial. And that is probably an underestimate. I'm sure many of the clinicians here, study coordinators, would probably even push back and say that's probably much higher than that. So what is the award amount and the duration? So the CIRM governing board has allocated up to $2.5 million for one award for a duration of 5 years. So this is a 5-year program. So the funds to support the financial needs originated from a patient assistance fund, which has a balance of $15.6 million derived from royalty payments. Now, the entire $15.6 million will be allocated to patients. And to be fair, 15.6 over 5 years is not a robust amount of money when you think about potentially 80 trials that are currently running. Now, the beauty of this program is that the fund can be replenished if new revenues or royalty payments are received. So if you think about the CIRM-funded trials, if any of them do go to marketing authorization, if any of them do have licenses, there is a royalty freed on the back end that goes right back into that patient assistance fund. So this can continue to support this program moving forward. And hence, there's obviously an opportunity down the road to scale to additional services for patients. Now, who can apply? This goes really to the RFA, and I don't think there's anybody in here that's that may be applying. But if you are, we are targeting profit as well as nonprofit organizations. We're specifically focusing on California organizations that can provide these services. Interesting enough, many of the organizations have gone to a total virtual program, so that's something that's new, and we'll start to consider that if that's something we need to modify with respect to the RFA. But at this point, it is specifically located in California. There are another additional requirements for applicants that we require. So we want the applicants to tell us a little bit more information. One is how the proposed project activities will improve access to CIRM-funded clinical trials by underserved and disproportionately affected populations. So we want them to come to us and tell us how their system's going to help this operation. The second is how the project team will bring diverse and inclusive perspectives and experience to the implementation of proposed activities. Activities for building cultural sensitivity and knowledge on the team and/or partner institutions, and how well the project team demonstrates a successful track record for promoting and valuing diversity, equity, and inclusion. And so when you step back a little bit now, the RFA is posted. We're now starting to hopefully receive applicants soon. This is a much more robust program that has a lot of interaction with other initiatives under medical affairs. So you think about the Alpha clinics, right? The 9 lead medical centers supporting the CIRM-funded clinical trials. There's an opportunity to collaborate with them, obviously, to accelerate information as well as patient accrual. The other, of course, is the patient care centers of excellence. There was a discussion earlier today, and this is one of the recommendations of us actually considering funding patient navigators out in the community. So you can kind of think about the patient support system as a hub, right? With navigators out in the community that can communicate with the hub. That would facilitate the speed at which we can get information to the patients and to the clinicians about the trials. And of course, we have 91 CIRM-funded clinical trials, which provide the optimal care for unmet medical needs. And again, the patient support program addresses the financial and logistical barriers to improve patient and research outcomes. So where are we now? So I mentioned the RFA is posted. This was a big lift for ourselves, for medical affairs, for CIRM. A lot of cross-functional departments gave insight, made this a much more valuable program. I won't go through all the deadlines, but the reality is that we are now, again, looking for applicants. And we've got a number of days to actually put the due diligence in-house to go through those applicants. It's a fairly systematic methodology, making sure we have the right applicants that we can take to the AWG, which is our Access and Affordability Working Group. Once we get their blessing, then we will take a final applicant to the board for a final approval and potential award. So with that, I want to say thank you. I think this is a really important program. Again, we're scaling small, so baby steps in the beginning, but this does have a potential impact to be really robust and help patients, not only out in the community, but also in the centers of excellence. So with that, I want to say thank you, and I guess I'll leave questions to the end. Yeah, all right. Thank you, everybody.
All right. Okay, and last resource is, this is the last of the resource panel. I have Daniela from UCI. And, one of the, when Daniela brought this resource forward, it was really exciting because, we talk a lot about technology. We talk a lot about the interactions of people with patients and communities. And one of the things we often overlook are sort of, from an organizational vantage point, how do you structure the organization and the programs? So those things really happen efficiently, they happen smart. And so I thought it was really nice that you brought forward an organizational model that I think can really help inform this, for want of a better term, this enterprise or this sort of this space we're working in. So in the spirit of organizational models, I invite you up to the podium.
Thank you, Jeff. And I'm glad to talk during your break, so please feel free to stretch. We can do some yoga before I finish if you'd like to. So just a few words of why I'm so interested in organization. About 8 years ago, we were the first theoretically community care center of excellence without being named a community care center of excellence. When we applied for the first time for an Alpha Clinic grant, we applied in collaboration with our colleagues at UCLA. And at that time, they had a very good structure, infrastructure, personnel, teaching programs, and we were just starting. So we had the opportunity of building in a very short period of time. And then you know how it goes. You should always think how you take what you learn and be able to teach it. In the end, that's the train the trainers. And that should apply not only for the Alpha Clinic and the community care centers of excellence, but how are we going to be able even further to disseminate the information in the field? So the way that we moved into dissemination was to think about my own macro network. And I mentioned a little bit before that we have 4 medical centers in 4 different counties. And we are transporting cell and gene therapy knowledge between those counties. That's Peter the Anteater, in case that you guys don't know the UCI mascot. And when you think about our micro network, the centers that collaborate with us in our micro network, what you could see, if you look at the colors, about in blue are the medically underserved populations, but in yellow are the medically underserved populations and areas. You could see that around Irvine, we have a high density of clinics and high density of high-level centers where we can administer those therapies. But as we go more closely to the inland empires, the needs are becoming larger and the infrastructure is not so strong. We also have a separate discussion, and I know my colleague, Dr. Issa, is going to talk about the VAs and the challenges that are on working with the veteran administrations, which are also special populations of people that are not necessarily on the same insurance programs. And even though they geographically might be very close to academic centers, the patients many times do not have access to the same abilities that we have access in the large academic centers. So, this changing a little bit the discussion. I don't know how many of you are familiar with CITI, but CITI was an initiative, is an initiative between Duke and the FDA, which now has multiple players. There are about 80 organizations, there are academic centers, community practices, industry sponsors, and their goal is to improve the practice of clinical trials. A good recommendation came in 2023, both as an article as well as a set of slides, which some of them will be reflected here. So I'm fully acknowledging them. Part of this is their work with some of my interpretation. And they are focusing, increasing diversity in clinical trials, recognizing the fact that this is not only important for representing and bringing clinical trials to our patients, but it's also good science and good business. It's the right way of doing it. And when they're looking at this, they have formed a framework, and next I'm going to show you actually they have formed more than a framework. They form a way of managing and benchmarking what it's taking to be able to promote this diversity in clinical trials. And as you could see, it takes partnership, commitment, resources, and accountability. And the partnerships, we talked a lot about them today. And there are people in this room that can talk about it so much better than I can do it. I can talk a little bit about the leadership and organizational culture, because that's the word on which I live at the institutional level. And the keyword is commitment. This is resource intensive in every institution. It takes passion, it takes determination, and it takes support. It takes the understanding that this is the right way to spend the healthcare dollars and the institutional funds. And then what I would also like to say is that we have to remember that whatever we do has to be sustainable, that we have to develop a model that is going to be here to support our efforts now, 5, 10, or 20 years later, and which doesn't depend on sporadic grant funding, and it is to be maintained through own resources after a period of growth. So there's a lot of thoughts about data-driven strategies, collaborations on ecosystem, really good recommendations. But what I wanted to show you here, because this was something that really resonated for us in our group, but I think it's going to resonate at a wider level with all the participants here, is that if we want to think about where those treatments will be delivered, we have to think maybe, at least Citi thought, that we need to think at a maturity model where we can score not only that we have a GMP and a clinic and an infusion center, but we have different numbers for each of those essential elements that we are seeing here, from partnership to commitment to resources and to the accountability, both on the quality of our data, but also on our ability to learn from our shortcomings, from our mistakes, learn from other people and other centers on the same work, and then take all of those elements and build them, go number by number, and all those shades of gray, I promise you, they have a certain definition in the paper, and they're well defined. And we maybe want to also benchmark our progress using a similar model to make sure that we have the access and the diverse participation on clinical trials. So going back to our small micro network, taking it from the Citi project to how we thought about it when we applied for the grant, those programs are happening in parallel. I felt very happy that the things that we generated together with the co-investigators on our real were very similar. Great minds think the same. No, the problems are general around the environment. And we came at that time, and we are working right now on our grant on trying to see what is the report card for readiness or the report card for needs on the 4 institutions that are working together to bring cell and gene therapies to those 4 counties, parts of the 4 counties, as I described before. And we thought about people, facilities, and processes. And those scores would be developed. We are, as you see, benchmarking our progress. We are defining what are our lacking points. And we are trying to bring more and more of the blue squares toward the yellow and the orange squares. Some of them might not be able to be present, the blue squares might not be able to be present at all the 4 institutions. And I know that we had the discussion about the hub and spoke versus hub and hub. I don't know if we need to have hubs everywhere for each clinical trial. Maybe we need a scoring system for the clinical trials. We do that all the time in big networks. Some clinical trials might be appropriate to be at multiple locations from top to bottom, from beginning to end. Some other studies should exist, in my opinion, as collaborations, bringing the most of the care close to home, but keeping the really risky, really specialized procedures in centers of high volume. I'm coming from neuroscience. We are looking at protocols to inject neural stem cells in patients' brains with all kinds of very advanced imaging and surgical technologies. Maybe those studies will be the ones that we will have to be on centers where people do those procedures day in and out at hundreds of cases. Maybe not. I don't know. The robots, all of those things that are coming, ChatGPT, I'm not sure if it can do brain surgery, but hey, maybe. Those thoughts, I think are going to be very important for us in the future. And more important from my thoughts are ways on which we do make and we do benchmark our progress. Because unfortunately, we are not going to be able to do everything at the same time. But at least on our micro network, we are trying to address the most immediate needs in community partnerships, engagement, and education. So I will close to what I think could be potential avenues of collaborations based on the Alpha Clinic ideas and how the city has informed us, but also with the community care centers of excellence. I think we can share common resources, some of them being infrastructure, especially the high-level infrastructure that I was discussing. I think we need to engage the patients and patients groups together. The community care centers of excellence will have many times unique access to unique populations, unique access to unique relations with community groups, with community leaders. So those things are gonna be amazing to have a bilateral and communication, and where some of the centers are gonna become the hubs for engagement, and where the alpha clinics might be the spokes, because they can do things, in my opinion, based on what I've seen as a proposal that we cannot do. And then I'll go back and I'll talk about sustainability. Clinical research, as I said, it's expensive. It requires resources and people. Maybe we're going to find ways together, from reducing the cost of CAR-Ts, which we heard a lot about, to maybe even simpler questions about reducing the number of questionnaires, or the number of lab tests, or the number of how many times can you run a 3 feet distance in what area. So let's try to think, how can we make it cheaper but better at the same time? We should be able to do education together. We talked a lot about that. We should be able to use data compatible systems, so data-driven strategies, including all our data, could be negotiated. And then I think it's important to remember that we have an alpha clinic network, but I think we're going to have an alpha clinic and CCTE network. And when our network is going to come from 9 centers to hopefully what's going to be 90 centers, or whatever the number is going to be in the future, how can we keep this ecosystem alive, thriving, and working? So thank you so much, and I'm happy to take questions or comments.
Daniela, hi. No. Just a comment. I think that's great, that color code. It's nice. It's a nice visual. What I think is really interesting, I would see that you would have blues to the UCRs and more of the communities for the navigation and the engagement. They are, so it'll be interesting in terms of, those are very well developed kind of in the communities, and to bring them into the tertiary care centers. That's a really great kind of bidirectionality.
We are going to take a short break because there's a break on the agenda. Thanks everyone for hanging in there. We truly are in the home stretch. We'll get through these last 2 sessions are going to be very critical, but we need a breather. And so we'll pick it up at 3:30, I think is the next. Yeah, let's just say 3:30. And so if you have questions for some of the folks too, you can catch them now during the break. Thank you.
define as many as 47 different aspects as part of the social determinants of health. So we really don't know if in fact we're catching all of them, but this is an environmental scan that I pulled up and put together for something else I did, and it comes from the U.S. Department of Health and Human Services. So when you look at it, here's economic stability, education, healthcare, neighborhood and built environment, social and community context. ASCA, AACR did a whole cancer progress report on social determinants impacting health disparities and access to clinical trials, which you might want to look up. Why do U.S. cancer health disparities exist? And they talk overarchingly, of course, racism, discrimination, segregation, structural inequities, and societal injustices. And I think that throughout the conversation today, you have heard it over and over and over again, coached or put into different language, used intermittently within what's being talked about today. We all recognize it. But I think at every table I have sat at, I keep asking, are you adding to collection of data social determinants of health? And then, of course, the big question becomes, which are those? Are we all going to be on the same page? Are we all collecting the same data? And are we all collecting it in the same way? So today, our conversation will be with our various experts who are standing by. But Christy, are you going to do something first before we move forward? Okay, so Christy Madden's going to present from her aspect, but I just wanted you all to see the list. I suggest that you take a screenshot of it and take it home and put it by your pillow so that you sleep with it, really inhibit it and keep it close to your hearts, because I think that it is very critical for us all to be sort of on the same page about what we really understand about social determinants of health. I think I'm going to leave this for Christy.
Is Alex online? Sorry.
Yes,
So we have
I'm
a
here.
line speaker first, and then we'll follow on. Sorry for the confusion.
So my
Thank you.
are screwing me up here.
Yes.
But I understand that we do actually have an order of presentation. I would be kicked off the set by now, you guys, with all of this craziness. But so we've got Alex Fajardo. He is with El Sol. He sent us Leticia. Oops, sorry, I'm forgetting to use this. So El Sol, as far as I know, has been in operation for 30 years, training promotoras, or as I say, AKA community health workers. The whole concept of promotoras is not new. You guys are just catching up. So let's bring on Alex Fajardo.
Thank you. Thank you so much. Thank you for the introduction. As you mentioned, I am Alex Fajardo. I am the director of El Sol. We are a community-based organizations that work with promotores, community health workers. We see them as a partners in how we can bring community transformation. And we embrace some principles that applies also in research. I'm gonna just mention a few of them, and then I pass to the next speakers, just to give you kind of an overview how we see research in the community. So a few things that we believe is that without human connections, change cannot happen in the community. Another principle is community participation is crucial to community health. So it's impossible to improve the circumstances without participation. Another aspect of our approach is that community promotores, community health workers, promotores create community solutions to a specific problem, and we don't see them just to someone that delivers a specific service alone. And the community should be at the center to decide for themselves what solutions they wanna solve in the community, what issues they want to solve in the community. Because the people most affected by social inequities must be the ones
who are involved at every stage in the process for any potential solution. So with these kind of principles, we really ask ourselves when we talk about research. So what is a community-based participatory research with the lens of a promotor philosophy or with the CHW philosophy? Is the CBPR really happening in the community? Is the research changing communities and the paradigms that our communities will live with? So I think what is the role of the community and what is the role of the promotores in research? I think that question happened a few months ago when we having a group of promotores talking about what is the role and what is the role of the promotores and what is the role of the community in research. So we came with a few conclusions that we'll be sharing through the process and in the conversation, because really research, we believe that research cannot be happen in the community if the community is not involved and if there is no an action from the community to move forward the findings of a specific research. Most of the research start in the desk of an investigator, and they are the ones who defines or identifies the problems and goes to the community to obtain data, focus groups, surveys, interviews, and they are the ones who make conclusions and recommendations, and then they publish a document to build their profile. And unfortunately, all of this doesn't help to community transformation. So I'm here to present how our agency and how our promotores can be involved in the community research. Thank you so much. I will pass my next speaker.
Hello, everyone. Hi. My name is Christy Madden, and I'm a clinical laboratory scientist and the laboratory manager at United Indian Health Services. I am a clinical laboratory scientist. I'm not a bioscientist. I'm not a doctor. I'm just somebody who loves her job. So is this how I change? So I want to share with you the background of this, the background of my slides. This is a painting that is in one of our clinics, and it's called Friendship. So I wanted to say, friends, I hope you enjoy my presentation. So who is UIHS? We're a consortium of 9 tribes serving, this is an error, I apologize, it was an error at 10:30 last night. We serve 10,000 Native Americans. We are located in Northern California along the beautiful Pacific Ocean and in the redwood trees. Some of you have heard the redwood curtain. Just to give you some numbers of our population, Humboldt County has a population of 134,000. Del Norte County has a population of 32,000. Just to give you a vision, Sacramento City, the population is 515,000. The Sacramento County is 1.5 million people. So just to give you a little perspective. And by the way, it's hot outside for us coastal people. So if we're sweating, we apologize. We provide comprehensive services. We have a dental, medical, of course, a lab, pharmacy. We do behavioral health. We have vision. We have a very successful diabetes program and a very successful tribal health. And we also have elder nutrition, where we go out into the reservations, and we provide food to our elders who do not have access to fresh food. We just celebrated our 50th anniversary in 2020, and we have 6 locations with 8 medical providers at the main location, and the other locations have about 1 to 2. Each location has a laboratory assistant for blood draws and wave testing. So I just want to explain, this is more of a clinical lab. We don't do cellular therapy. We do not have an oncology department. This is just me telling you a story of success and community. So just want to share some pictures with you. In the upper left, that's a picture of our medical center in Arcata. And as you can notice, the rooftops are very different. They are replicated from the ancient housing for Native Americans. In the middle left, those are individuals in their regalia and beaded and their caps. The next picture over is some caps that have been hand woven and represent different tribal symbols. The one on the right is actually a baby basket, and we see these in the clinic a lot. You can also, they have abalone tied to them, so they rock the baby and the abalone calms the baby. So they're really beautiful to see. The bottom left is actually a picture of our front door, and it's a circle, and the clinic is already in an entire circle to represent the circle of life. In the middle bottom, we do summer camps for the Native American youth. Right there, they're learning how to do weaving. They learn how to do beading, how to do various dances and prayers. So we're all about community. And then in the bottom right is from an artist, Liz Riesling. She's a very famous artist in the area. And this again is showing the circle of life from a baby all the way up to an elder and then to the deceased. This is a map of our services. The top is Del Norte County, the bottom is Humboldt County. But we also do have Native Americans in Trinity County, which is on the right. And above there is Curry County, which is in Oregon, and we also service that county as well. Again, here's some more pictures of our culture. And on the bottom right, if you see an elk sign on the road, you're probably going to see an elk. So why did we expand services? About 5 years ago, I came to this clinic and I witnessed about 100 and 150 tubes of blood being sent down to a lab in San Diego, most often getting lost or rejected. And I said, we're not going to do this. So I came up with a vision, and my board of directors wouldn't even let me finish my sentence. And they said, how quickly can you do this? And are you going to stay? Because it's very hard to find clinical laboratory scientists in these remote areas and be able to get them there. So I made a promise I'll stay. So within 5 months, I had a high complexity lab. Why did we want to do this? Because they were waiting 3, 5, 7 days for results. With this, we can do improved patient engagement. Hey, your glucose is 400. Now let's do your A1C. Okay, let's march you over to the diabetes program and get you an appointment. We can make quicker medication adjustments. We can diagnose and treat faster because we're going to get them that same day, next day results. The others, we're going to provide behavioral counseling, set up other appointments with the nurses and the MAs to really check on their progress as to manage their chronic care. Excuse me. So things to think about when we were doing this. And I think my Humboldt crew is thinking, okay, what does Christy need? What kind of space do we need? What equipment do we need? What SOPs do we need to get this boots to the ground, open the box, and we're ready to go? So things I had to think about when we were building the clinical lab is space and design. Medical got mad at me because I took 2 of their patient rooms. All heard that for a while. So what other departments? We had to look at IT. What kind of connections? I had to look at our electronic health record. How is that going to impact the electronic health record? Fiscal, this is going to mean we're going to have some more money coming in. Facilities, who's going to clean the thing and how do we clean it? We needed to expand our courier services. And of course, receiving is going to receive a lot more packages to supplement this lab. And also the important thing when doing a project like this is you get them invested in the project. You make this their project so that they can say, we did this together. I evaluated our current reference lab bill. To this time, I've reduced it by 86%. I'm going to show you a test menu that we thought were the most popular tests to bring into staff. Staffing, I'm going to need a CLS. I can't just do it myself. So we had to find one, and we needed to hire about 2 more laboratory assistants as well. We needed to look at the instrumentation that we wanted to purchase, and we needed to look at a laboratory information system. Are we going to buy these instruments or are we going to rent them? Construction timeline. As I said, I had a high complexity lab in 5 months. I come from the Cleveland Clinic Foundation. I come from Los Alamos National Laboratory. This is a record. Usually it takes years to get this kind of instrumentation and construction to happen. Again, we're going to look at our proficiency testing and our calibration verification programs to make sure that we're doing due diligence, that we're doing what everybody else is doing, and we're all doing it the same way. The next was the most difficult and frustrating to do was changing our current license, going from a provider performed microscopy license, which is just doing point of care testing, just poking someone's finger, to doing a high complexity lab. It took about 1.5 years. So if you're looking at doing something and all of you with your IRBs, I can already see what limitations that they look for you and what are they going to tell you that you can and cannot do. So this is a test menu for a clinical lab. We do metabolic panels, thyroids, uric acids, A1Cs, iron studies, vitamin studies. We recently added on hepatitis and HIV, syphilis, and GC chlamydia. Unfortunately, a lot of those are prevalent in our community and throughout our clientele. So COVID, remember COVID? March 2020, we all shut down and said, oh boy. So I remember it specifically. So I had an instrument called a Abbott 4100. It's a very large chemistry analyzer, like as big as the tables. And we were the first ones to get this test called a COVID IgG. And it just gave you a qualitative. Did you have it? Did you not have it? So I came up with this silly idea. Why don't we offer this to our first responders? You know, we don't have the PCR test. They're just developing the kits. They're just developing the tests. So we went out and drew 12,000 first responders just to see if they were positive or not. What this did is took UHS out of the shadows and put us at the forefront, that recognized that a Native American community and clinic put us out in the forefront, and look what we could do for the community. So I'm very proud of that. I'm glad we did it. Some of you are like, IgG, that's so silly right now. But at that time, it meant something to somebody. So I remember the day, it was my birthday, August 8th. And I get a call from the public health laboratory. And they're like, we've seen what you've done for the community. Some of you may have heard about the PerkinElmer equipment that the state of California got. Well, it's just, you know, the equipment to do the nucleic acid amplification for COVID. So we see what you've done in the community. Can you help us? Let's partner with Del Norte. Let's get some help from, at that time, Humboldt State, which is now Cal Poly. We're like, sure. So talk to everybody. We all got together. We identified a space that we were going to put the lab at UHS. We established a courier service. HSU donated a biosafety cabinet. We actually had HVAC electricians and plumbers drop what they were doing and saw what we could do for our community. And they came over and said, we'll be there tomorrow. So it was really nice to see how the community came together during this pandemic and worked together so that we could do testing for our community. The NCT partnership has ended, but at the end of it, we did 55,000 COVID tests. And that's a lot for our community. I know those of you at UC Davis and Stanford, you probably did 3 or 4, 5 million, but that is a lot for our area. So with that, we built a BSL-3 level lab in 4 months. We got this started on August 8, my birthday. Right now, 3 years later, I'm not sure how good of a birthday present it was, but let's see. December 13th, we first started doing testing. So 4 months, pretty good for a little community. We had Cal Poly students come and work for us. I had about 8 of them who graduated in biology, cellular biology, and microbiology, and they were really great to work with. But what also gave them the experience is you're just not going to go in the lab and pipette stuff. You're going to document. You're going to graph. You're going to do all this paperwork. You got all this registration and patient intake. So I think it was a great experience for them, just thinking, I'm just not going to go and work with liquids and set things on fire. I'm going to do paperwork. So as I want to end my story, I want to thank Connie Stewart. I want to thank Dr. Sprouse, and I want to thank Dr. Liu for including me in this project. I'm really excited. It's maybe another lab I get to build. So again, thank you for your time. It's just a story I wanted to share with you. So thank you again for your time.
Thank you very much, Christy. If you'll step on down. So Dr. Naranjo, in terms of, you can pick up a mic there. When you're talking about the determinants impacting program development, and you adapted niche in order to start to address those, how do you see expanding that for the cancer, or I keep wanting to put cancer in there. Sorry, folks, it's a cancer with me, cancer. The community excellent care centers.
That's a big question.
It is. We don't ask little questions at CIRM.
Yeah, I don't know. I think that with our very limited and new experience at Stanford, seeing the places or holes or areas that niche could help, again, think of us as a spider web, be this web that pulls systems, physicians, teams, and all of the care resources together. I could imagine that the possibilities are endless if there was a way to utilize the model and have interventionists across multiple communities. We are currently just cleared, like last week, to hire a 5th interventionist that will be embedded in the Valley, because a lot of our interventionists are near Stanford, and we kind of cap them at 2.5 hours each way, just for their quality of life. But if we have someone embedded in the Valley, then their catchment area would be a lot larger. And so in thinking about that model of sending our interventionists to the communities, like up to Humboldt or over to Fresno, or even down further in Southern California, depending on the clinical trials in the area and the need, I would imagine a similar system. It would be challenging because a lot of what we do is embedded at Stanford or UCSF, but I'm sure that we would figure out how to overcome those challenges to make sure that we're the glue.
So you're talking about shaking up the system.
Yeah,
okay,
very much.
So let us define interventionist. Are they the same thing that we are calling promotoras or community health workers, or does it require a higher degree of education?
So at Oregon, which they have, I think, 25 or so, their program is much larger than ours. they have a range that requires a high school degree. At Stanford, because of our HR and all of that, it requires a college degree, but it's not within health necessarily. A lot of our interventionists have experience of having a child with chronic illness or having a chronic illness themselves, and then we're marginally interested in health. And we have a lot of work that we do around medical jargon because they have to chart in my chart and Epic, and on how to navigate medical situations. But it's I would say a hybrid between a promotora and a community healthcare worker slash a little bit different. Yeah.
And I think that as we work through this is what we're trying to do, is adjust the models.
Yeah.
But they could stretch across the continuum.
Yeah.
One hands off to the other, hands off to the other, but there's that continuum. So Mr. Fajardo, obviously you're working with promotoras, you're training them. You've got many training programs that you've set up. I see this as building capacity, investing in underemployed women, putting women to work who are linguistically and culturally appropriate. And excuse me if I didn't say men, I know there's some men promotores. It builds bridges between systems and community and between science and community. How do you see which model, or how would you adapt a model knowing the community and linking back to these community centers of excellence? How would you develop the program to work with CCCE? You know what I'm saying, Mr. Fajardo, because
Yes, thank you.
oftentimes they come to you and say, here, do this. But things have to be readjusted in order to work for the community and to do the outreach you need to do. Can you envision in your mind, in a very quick amount of time, what that would look like?
Sure. I think it will be a few steps. First of all, I think there are two ways to work. The first one is to really challenge the system. I think how the metrics on how researchers are judged by the institutions are not aligned with the community action participatory approach, because they are valued by how many published papers, how many sites, and so forth. So I think that first we need to have some conversations with the investigators and how they can support the research led by the community, with the community. They need to be part of every steps of the investigation and the research. I think that's the first steps. And the second part is really how we can develop these skills in promotores and CHWs, and how to facilitate engagement in order to gather the community to participate and develop their own research, whatever topic they are going to resolve. So I think it's to both sides that needs to be developed, and also valuing both sides, the researchers, the investigators they are experts, but also the CHWs, promotoras are experts in how to work with communities and being on the same level of respect and let them to do the work in each area. I think it's both sides.
And one of the things that I heard throughout the day from different presenters kept taking me back to the word respeto, respect. You have to come to the community with respect. I think Leticia said you have to show respect for the promotora because they are your bridge and your link. I would say, Christy, in the Native community, it's the same thing. You're coming and asking with a great deal of respect. And first, you need to know their culture before you say, this is what we need. Button down. You see it?
There, good. Yes, and that was one of my first. I started in August, and Halloween came, and I found owls, and I put owls on the cabinets. And one of the elders said, "Chrissy, you can't put those there." I said, "It's an owl, it's Halloween." "No, an owl means darkness is coming." So out went the owls, and I found pumpkins. So, and I was very fortunate to have an elder to work with, and she taught me so much on how to approach a Native American. Because for some of you who have gotten your blood drawn, it can be a very intimate experience, and you need to be very respectful and very kind. So I learned a lot from her, and again, anything that we can provide additional services to our Native American community, they are grateful for that. They understand the lack of services in our area and other areas. So what we can promote them and give them culturally appropriate treatments and explain those treatments, then they will welcome you.
So you're talking about education, just raising awareness for them so they can consent in the appropriate manner once they understand what they're getting into.
Yes, and we were speaking last night with Jeff, and I've just noticed being in the science community and being in the Native American community, they come and seek us for more information. They want to know more about the science, and they want to know our opinions and what we think. And I was just at a health fair, and I just had the little Cepheid cartridges just sitting out on the table. I want people to look at it. And they were fascinated. They're like, "Well, how does this work?" So I, showed them, but they were just fascinated to see what the little Cepheid cartridge looks like. So, so I just noticed in our community, science is more of a knowledge. Before, science was we were afraid of it. But since COVID, people want to know more about science.
Absolutely. I think the other thing that I noticed in the work that I have done in community is that people come to you and they want a lot from you and they want to give you very little, or think that you're going to do it out of the goodness of your heart. And you're saying, so both you and Mr. Fajardo can answer this. Do you get to put the price on your services, Mr. Fajardo?
Yeah, actually, it is interesting when someone come to us and say, "Hey, Alex, can you help us with this research? Can you help us with these surveys? Can you help us getting some focus groups or help me getting interviews?" In the past, we would say, "Yes, we're here for the community," and we find out that most of the research were without the people, and the research was not for the people. So right now we are putting research with the people and for the people. And then if they want to have the community involved and really to let these interventions of this approach with the community, they should be getting reimbursed the hours that everyone deserves to get paid. So definitely it's really many of our promotoras, or CHWs, they do a lot of work from their heart. They stay over and over with the community, and they move what they need to do in the community to make it happen. But I think they deserve to get reimbursed and support. But it's not just really like getting reimbursed, it's really what the investment is for the research, whatever it is, needs to bring a social change in our end. I think any research that we want to support as a community organization should aim the social change. So how the lives of the people are going to be improved with this research, and how we can get people together to develop this research so they can take action. And really, we're going to be impacting the social determinants of health that we want to aim. So I think that's how, and then the investment needs to come to support not just the daily things or the surveys and things like that, but really the infrastructure to really bring social change as we do the entire researches. Yeah.
Well, would you suggest that it is a sign of respect, Christy, that they say, "We want you to do this. How much is it going to cost us?" As opposed to, "Here's 25,000, do all of this, please." 100. Well, I think actually we need to teach community health organizations how to put a value on their services.
Yes, and I agree. And there's a new California Partnership in Health, which is a statewide insurance. They've actually added a new arm to their coverage. So maybe if some of you with a community health clinic may have heard of this or not, but if you have a community health worker or someone who is a cook or someone who is providing transportation to a partnership client, that you actually can get them reimbursed for their services. So that's a new community thing that we're really working on in our community, because some of these elders, they have a healthcare worker or they have a personal assistant and they can't afford to pay them. So we can, again, help them get these services submitted where partnership will reimburse them a little bit of money. I have to agree with you, sir. We need to, your point of making research applicable in our communities. It needs to be, I hate to say the word simple, but simple and clear. That how this medicine, how this new therapy can really impact their health. When we first had the lab, being in a clinical setting, we had a young individual, 14 years old. For me, this is probably the highest WBC count I've ever seen of 396. And I didn't even have to look a slide under the microscope to say it was acute lymphoblastic leukemia. We had to go have a community health worker go to the reservation to pick up the gentleman. We organized the ER apartment. We organized him getting flown down to San Francisco. This therapy would have greatly reduced the time that this man would have spent in the hospital and the amount of chemotherapy that he received. So I always think of this person who is near to my heart, and I see how we quickly identified a problem and got him some treatment. But then as I hear more about this, I see those individuals that we've benefited with getting same day, next day care. But then I'm also looking at this therapy saying, you don't have to go through that long of a process. We can get you some help a little bit sooner.
Well, since we continue to look through this particular lens, social determinants and how they impact the creation of this program, one of the things is that if you're going to use promotora as a community health workers as interventionists, they need to be healthy. Therefore, they need to be duly recompensed. Therefore, because they choose to work weekends, weeknights, in order to, in fact, deliver the work that needs to be done for the community. And therefore, that's very high value. I don't think too many people who work in regular jobs don't expect to be paid, not, overtime or weekend pay when they're doing this. And so I think I quite frankly think that there needs to be a lesson in learning how to put value to what you deliver, because and create budgets that in fact respond to that. What would you say, Dr. Naranjo?
Yeah, I absolutely agree. I think we're fortunate that we have good budgets for salary, but even with a good budget for salary, and even with people that are coming to this because they have personal links to chronic illness and chronic illness management and passion, people get burnt out. And so we have weekly check-ins with the supervisor that are self-rating and supervisory rating, and a discussion about how their mental health is, how their overall commitment is to the program, how they're feeling, areas of burnout, and really trying to prevent as well as bolster the wellness of our interventionists, because they have children that are greatly impaired and they're working nights and weekends. To be clear, they're not working more than 40 hours. We just make sure when they're available is coverage. Right. And so if they work a Saturday all day, then we make sure that they flex time during the week. But some of them will occasionally go more than that. And so we pull them back and make sure, because these are such passionate people that they want to do more. And so we spend a lot of time thinking about burnout and how to prevent and protect.
Well, I think one of the models of the CCE CCCE is that in fact it corresponds to the needs of the community and not the other way around. So it's not a 9 to 5, Monday through Friday kind of a response. You know, these clinics will have to be open and available to the patient when it can, when that person can participate.
Everybody's crisis is 5:30 Friday. Just prevent a lot by knowing that. Yeah.
Yeah.
On a 3-day weekend.
But I think, but we've seen this happen when you demonstrate to, as we did down in Monterey County, to the federally qualified healthcare system that patients were open and ready to come, just not on 9 to 5, Monday through Friday. We had some gynecologists adjust their hours on weekends and evenings because as we've talked over and over again, respect for patient and showing that you care and that you recognize their humanity and their needs is responding to how they need it and when they need it. And some of the research that we were doing, talking about calling a patient only 3 times before that's harassment, we called them 10 or more times, and when we couldn't anymore, and we said, oh, we signed up 8 and we lost the other 20. I said, I want to know why we lost the other 20. Why, what, maybe it's that last call, right? That one, they need more calls. And so I think that we have to know that this particular project and program has to operate outside the box and not in the norm. When we're talking about really inclusion and diversity and equity. So how would you, in your mind, Christy, institute such a program in your area with the Native American community you work with?
It would be education and simple, direct education. Time's up. With respect but also I'm going to say Humboldt is a unique population. Me coming from a large healthcare organization, we also have a lot of anti-vaxxers. We have a lot of non-medicine, not only our Native Americans, but in our Humboldt area. So it's been hard the past couple of years, especially with education for vaccinations, and even some of them who don't even have their measles, mumps, or rubella. Getting that education out in a simple and well-known way in the media is really how it needs to be done. And then it needs to also be within the clinic. I've said to our meeting last night, we have providers that are going to be like, no, we're not going to recommend this. But there's going to be those few providers that are excited about new medicine and are going to say, yes, we want to do this.
And so, Mr. Fajardo, for you, the last question. We know that Latinos are highly mobile, about 80% or more. We also know that during COVID, between Facebook and WhatsApp, at least 50% of the information they got around COVID was disinformation and misinformation. So how do you try to educate a community around these very complex issues, but educate them where you can reach them when they need to be reached or when they can be reached?
Yeah, I think that's important about the relationship. That's why we believe without human relationship, change cannot happen. So I think that's super important. It's not just calling the person or like following up with them. And a phone call is really developing that relationship and sincere support. I think that's the first thing, developing that relationship. And maybe they can even call the text, hey, by the way, when we can follow up and start developing that relationship, I think is more important than even giving the information. And then as soon as you develop the trust and all of that, you can start little by little incorporating the topics they need to develop. And then I just want to say something about when we work with community, especially when we're trying to do some investigation and research, is that the idea of in our point of view, when we incorporate promotores and CHWs in this work, is not just to develop or to provide a service. It's really how we can empower this workforce to really mobilize the community to take action. In the meantime, I'm doing this and that, I'm really empowering the community to take action. So I think that's important. They just want to be, and that needs to be organic as they develop the relationship.
Absolutely. I think even Christy mentioned it. They're part of the power dynamic of this project. They're key to this project and its success. So when they know that, I think they engage with a whole heart. Thank you very much, Mr. Fajardo, for joining us, Christy Madden and Dr. Naranjo. Very good. Thank you very much, everybody. Okay, Mr.
Stephanie, come on up. And everyone in the room blesses, thanks you for that. And do we have Tony online? Okay, so this would be kind of more of so just to give the audience a little bit of context, we've asked the next couple of speakers, they've been sort of viewing and listening as from organizations that have a keen interest in this program. But we really wanted to have them sort of hear the day and then kind of give kind of their feedback in terms of like, you know, what do you think? And so if you could introduce yourself and kind of explain what you do and tell us what you think.
Can you hear me? My name is Stephanie Farrell, and I am a research coordinator that started at a cancer center about 19 years ago. Can you hear me? No, my mic's not on. Can you hear me now? Let's try that. My name is Stephanie Farrell. I work at Eisenhower Health. It's a community hospital, community cancer center down in Southern California in the desert. Rancho Mirage is the city. I started out 19 years ago there as a clinical research coordinator in the cancer center, and went to nursing school about 10 years ago. Became a nurse. And I have been implementing clinical trials for the last 19 years in our community. We had not a lot of clinical trials going on, and we partnered at that time with Stanford Cancer Center to open National Cancer Institute clinical trials in our community. And I look at our experience we had with that, and I think there are so many parallels between what we did with those NCI trials and what you are trying to do with stem cell research. And I had not even heard of CIRM, didn't know what regenerative medicine was. I've been living under a rock, apparently. It's been very busy at the community, at hospitals in communities the last few years. Until 4 weeks ago. And so I've been like Googling and trying to figure out what this all is and what it all means, and trying to fit that in to my daily work and manage my clinical trials office and research and everything that goes on at a community hospital. I wrote a whole bunch of things down, so I'm just going to tell you my impressions. Such an inspiration to listen to you, and just a message of hope when I hear about what you're doing. And when the patients were speaking about their experiences, it makes me think about my patients who were initially getting immunotherapies for metastatic melanoma and metastatic lung cancer going back to 2008, when those were still in phase 2 trials. So just so inspirational, and just really impressed by all the really, really smart people here. And I almost feel like, oh gosh, what am I doing here? I don't think I belong. I don't think I belong here. But here's what I know. I am a patient advocate, first and foremost. I want to bring novel new therapies to my community, to the Coachella Valley. I do not want patients to have to drive and drive and drive hours away to get treatment for cancer or anything else. I have a daughter with severe asthma and allergies, and I'm always looking for new, exciting treatments for her. I have a dad who has macular degeneration, and I saw that there's trials for that, and I'd love him to stop having to get bevacizumab injections in his eyes every month. I have a friend who was my partner at the hospital in quality that was a surgeon, had to leave because he's got MS. And so I'm constantly on the hunt for clinical trials to bring to him. I'm just trying to think about all the different conditions that I read about. So I look at, and let me make sure I really understand this. The community care centers of excellence, you're trying to bring treatments to community settings. Is that what that's what that means? Right? Okay, good. Okay. Because I think I have some, I for sure have some nurses that I can think of a few nurses who would love to do this with me. And, you know, I got to make sure my, obviously the most important thing in any clinical trial besides the patient is the physicians, because nothing happens without a principal investigator and your physician. And in a community setting, very different, very, very different from academic. No one's getting paid for research. No one's getting paid for writing papers. So we do get reimbursed a little bit from industry for clinical trials. My personal experience with this is that industry does not want to pay me what it costs to do clinical trials. I am constantly battling with them just to get them to pay me a little bit more than what Medicare pays me for clinical work. And that is, it doesn't meet their fair market value is the statement, but they can't refer me to a publicly available fair market value list where I can see, you know, what they just got some, you know, someone not so astute to agree to take that money to do that exam and that infusion and that lab. And so that's one of my challenges is industry doesn't pay us, and we don't really get grants at my place where we're doing clinical trials, which is most of the work that's done. We're not really doing research. We don't have any bench research. There's very little research going on. It's all clinical trials. It's getting treatments to patients for cancer, pulmonology, neurology, orthopedics, for devices, cardiology, trying to think, HIV, and infectious disease. And who was that? Christy, you're like my sister. And when I heard your story, it brought back all these memories from June through December of 2020 and COVID. And at that time, I was working with one of our infectious disease physicians, Dr. Ken Lichtenstein, who's now retired. But we were able to partner with NIAID to bring COVID clinical trials to the desert. And because we were able to do that, we were able to open a COVID monoclonal antibody clinic to treat patients with mild to moderate COVID. And we opened that clinic in literally 16 hours. There was a huge alert that went out to all employees in the health system. And this was, I think, on like December 17th of 2020. We were on diversion again. And, you know, all of us have been in place working for the last forever. No one's working remote at our place. We are showing up to work every single day. And people everyone is just working and trying to treat patients and see patients. And a lot of other things have been put to the side. But when that happened, I went 6 a.m. I drove into my hospital. I went to my CEO, and he was the COO at the time, and I reported to him. And I said, we got to open a clinic. We got to open a monoclonal antibody clinic, and I know we can do it. And if you just give me, some construction people and some resources, we can do this. And fortunately, we'd been shipped the drug. It was sitting in our pharmacy. And I'm like, we got to get it to our patients. It does no good sitting in the pharmacy. So he literally said yes. And I had a team of people in an empty, abandoned clinic. And we started working on that at around 7:30 a.m. By 10 o'clock at night, I left, and the infusion pumps were working. The electricity was on. I had computers so we could chart an Epic. And I met my doctor the next morning at 7:30 a.m. and we started treating our first patients, and then treated another 1,200 patients for that. And that's fitting around what's going on in all the other oncology trials and everything else. For the cancer center, I was listening to all the challenges, and I thought, gosh, I didn't realize how fortunate we are. We're an American College of Surgeons, Commission on Cancer accredited community cancer center. We see about 2,000 patients, or we have 2,000 newly diagnosed cancers every year. We do see thousands of patients, but it's all about patient-centered care and building that relationship with people. And we do a distress screening on every patient who comes in. We identify any barriers they might have to care. We have oncology social workers on site. We have financial navigators. We have nurse navigators. And they're in Spanish and English. We've got Language Line, which is an app on an iPad if we need to, translate in any other language. And we also have nutritionists. We have philanthropy. What we don't have in grants, we make up in donations. We have an incredibly generous population in our area, in our Palm Springs area, and they donate money to take care of patients. And so when I heard about the transportation issues, one of our donors raised millions of dollars to buy cars and vans to transport patients from their homes to the cancer center to get treatment. And that's still in place today, even though our donor is gone. And she actually got inspired to do that because she was in radiation therapy every day, sitting next to another patient getting radiation who was taking a bus 2 hours every day to get her radiation and then taking a bus 2 hours home. And our donor who was sitting next to her said, oh no, this is not, let me do something. We got to fix this. And so she not only fixed it for her, but all future patients, which amazing organization. We have, social workers, oncology social workers, there's therapists, we have support groups. We partner with the Desert Cancer Foundation. So if people can't afford their treatment, because just because you're on a clinical trial does not mean it's free. And gosh, I spent 6 hours last Friday navigating a patient who had to get, or didn't have to get, but volunteered to have a TAVR, that's a valve replacement, on a clinical trial. And his insurance company had a carve out and doesn't cover his clinical trial. And the company wouldn't cover it because it's a CMS IDE. And so it should be covered under NCD 310.1. So if you know anything about Medicare, it's a beautiful thing. The FDA and Medicare have gotten together, and if it's a qualified clinical trial, they will cover treatment for patients, right? That's awesome, except for if you're not Medicare, that's one. and and your insurance as a carve out. Or two, if you are Medicare, fortunately, this guy, he's 78. He's one of my coworkers. He is working full time as a medical assistant in one of our primary care and infectious disease clinics. And his secondary is Medicare, except there's a $1,800 responsibility out-of-pocket patient for him to be on this clinical trial. And anyway, the company wouldn't pay for it. I think we're going to get it paid for by my, administered by my bosses, my executives. It's just like, it's tough for patients. It's really tough. Just because it's a clinical trial doesn't mean it's going to get covered. I actually think, people with significant conditions and diseases, they're looking for treatments. And, if you take the time to meet with them, and every patient I meet, I've consented hundreds and hundreds and hundreds of patients over my time as a research coordinator. And if you get the time to know them and listen to them and really talk to them about their treatment options and why this might be reasonable, and you have your doctor who suggests it, I think you'll find that you can get those patients to stay with you forever. We still have patients we're following that I enrolled 18 years ago, and we'll pick up the phone when I call so we can check in on them and do their, long-term survival. So when I hear the relationship building, it's not just the programs, it's just people. It's making connection and finding those people who care enough and look at their patient and go, that could be my mom, my cousin, my uncle, and how would I want them treated at our place? And what else do I want to say about this? Let me flip my thing about because I was writing down some of the challenges. The opportunities, I think, if you can model this right after the NCI's NCTN network, the NCI's been doing this for, I think, at least 20 years, if not longer, where they're going out and getting community places to offer treatments to patients. It works fabulous. I love the CTSU, if you've, any of you on college. Are there any research coordinators here, by the way? Okay. A couple. And how about research nurses? Oh, okay. Excellent. I would love to connect with you. If you do CIRM work, I want to just pick your brain on the reality of operationally what it takes to do it. Let's see. But the NCI has a great model, and I think you could leverage those existing places to do this work. I need to learn more about stem cell treatments. I think the only thing we've ever done at our little cancer center is Provenge, and that was a number of years ago for prostate cancer. If anybody knows what Provenge is, did a little bit of it, but it was a long time ago, and we're not doing it anymore. If anybody wants to send me some videos and about this so I can learn more, I'd love to learn a little bit more about it. But the other challenges I was thinking about are, okay, in a community hospital, the way our doctors get paid is visits. They're seeing 20 to 30 patients a day. So that's kind of normal. And the way they get their paychecks is seeing patients. And if they're not seeing patients because they're in an investigator meeting or they're doing training on the clinical trial, their paycheck is affected. And no pharmaceutical company, even if I get them to pay $400 an hour for my physician, which, I think the NIH rate is like way less than that. But even if I can get a pharmaceutical company to pay my doctors, they are still losing money and bonuses and all the rest of it. And that is just the reality. None of us are being asked to take pay cuts to do this work. And we shouldn't ask our physicians to do that. And then the other part of that is in the hospital-based clinics, because we've gone from a hospital 10 years ago to now we're a hospital with many, many clinics all over the valley. All of those hospital-based clinics, there's something called facility fees. So every Medicare patient that comes in, I think it's about $139 per patient visit that the hospital gets reimbursed when a patient comes in. And that's another sticking point. Industry doesn't want to pay for that. And I know a lot of people think it's ridiculous, but the reality is there's a lot of things that we have to do as a hospital-based clinic that a entrepreneur, single practitioner, or private practice physician doesn't have to do. Like a private practice physician, if they want to have, an unlicensed person draw blood, as long as they've trained that person, it's under their license, they can do what they want to do. If they want to have maybe not a pharmacist mix chemo, they can do that in private practice. There's Joint Commission's not going to come in, the state's not going to come in, the California Pharmacy Board is not regulating them. That's in our world for community hospitals and clinics that are licensed under the hospital's license. We're like the 5th floor of the hospital. So Joint Commission, gosh, they've been here for 3 days. I've gotten hundreds of texts about Joint Commission things just in the last, 24 hours. And so Joint Commission, the state, the Pharmacy Board, they hold us to a much higher standard, and that facility fee helps mitigate that. But people don't, people who ask us to do clinical trials don't want to pay for that. So we got to figure out a way. How do we protect our physicians' time so that they can do these clinical trials? How do we protect their time? And I think it's going to come down to dollars and making sure the physician is whole when they do clinical trials. I also think, there's just, we still have tons of registry staff and locums. I think I heard a statistic, something about like 24% of our salary expense was being spent on 9% of the people, because we've got tons of registry and locums to fill the gap. And when I think about doing these trials, I'm like, okay, who can do that? What specialists can do these? Is it just medical oncologists, or can I have a family practice or an internal medicine person do this? I don't know. I don't know enough about it. And we don't have enough family practice, internal medicine, and specialists to see our patients right now, which is why the health system has started a GME program about 10 years ago to try to start getting physicians trained and staying in our area. So I think, okay, do we have enough physicians who could do this work and support patients? And I already know those patients are completely booked with, waiting lists of like 3 months to get into a neurologist. And so how do we continue to resolve that? And clinical research coordinators, research nurses, my clinical research team has had 100% turnover, 100% turnover in the last 3 years. I'm sure you can see, I used to have brown hair. I used to look pretty young, and like, I'm just like, it's been pretty challenging the last few years. And so now we're bringing in where I used to get applicants with PhDs and all this experience for research coordinator positions. I can't find anyone to work because no one wants to work at work. Like they want to work remote. And, it doesn't lend itself to taking care of patients, because who said it's a contact sport? Someone said that. And I'm like, yes, it's a contact sport. I need to be with you, with my patients, and remote and Zoom does not work. So starting a training program where I take new college grads and bring them up to be certified clinical research coordinators. I'm working on that, but that's it takes a lot of time. If you've done clinical trials, it's a steep learning curve. And what else? Yeah.
Maybe, can I just ask a favor here at this point? Because you raised a really important point about the physician's time and that issue. And I just wanted to, we have Tony online, and a similar issue was raised. So Tony, could you perhaps introduce yourself? And I know this was there's some themes here. I'm just wondering if I know a number of themes you echoed. So would you like to sort of just comment in terms of the reactions as well?
Yes, thank you very much. Can you hear me?
Yeah.
Yeah, so this is a big challenge for us with a busy clinical service, is especially for young investigators who wants to get into clinical trials, to get them protected time. And I think I feel for them, but I also feel for the chief of service who is responsible for covering the clinical service and doesn't have a choice, and doesn't want to look like a bad person trying to stop that person from doing a clinical trial. So I think we have responsibility as a society to try to do something about this. And one of the options is to, when a sponsor provide a clinical trials, try to provide protected time, coverage for protected time in terms of financial funds to the institute.
And could you mention sort of your work with the VA, and so your idea of a sort of networked approach and the opportunities within the VA, specifically around the sort of the ideas you shared about how you might envision a VA role in terms of the research?
Yeah, and I have some slides. Is it okay if I show the slides?
Yeah, it should be. If you have does he have screen sharing ability?
Yeah.
There you go.
So I'm Tony Issa. I'm the Associate Dean for VA Research, University of California. I work with Dr. Bota. You heard it. As everybody said, I'm really humbled and inspired by today, but I'm not going to spend time talking about that because of it's late during the day. So I will go just to the point. And one of my jobs is to implement the VA research's strategic priorities. And number one priority is to get veterans access to high quality clinical trials. So even though the government is really very supportive of veterans and have all these hospitals for the veterans don't have access to really high quality clinical trials. And definitely they do not have access to regenerative medicine. And I hope that California will be sort of a model for the rest of the country in getting regenerative medicine into veterans. And I met with the VA director in Washington last week, and he's extremely excited about this possibility. And I will talk offline with you about that later. But basically, what I want to emphasize today, that when I heard this presentation and I heard another presentation a couple of weeks ago, all the stuff like neurodegenerative disorder, that stem cell are used for spinal cord injuries, traumatic brain injuries, stroke, blindness, cancer, sequela of toxic exposure, lung injury, burn pit exposure, all of these are really amenable to therapy by stem cells. And these are the most prevalent among veterans. And unfortunately, they really have no way of accessing this. There is a glimmer of hope in University of California, Irvine, due to Dr. Daniela Bota collaboration with the VA, that we're trying to start this process. But there are challenges that clinical research coordinators at the VA do not really trained in stem cell research. We don't have experience in the regulatory requirement specific to stem cell research. And we need educational and training opportunity and protected time, as we just talked about, for new investigators. But there is a lot of opportunities on both sides. So the VA is one of the largest healthcare enterprise in the country and has one of the largest database for healthcare. And it's large and diverse patient populations. And it also has extensive and well-established clinical research networks. And this is the VA collect all these data and put it in a warehouse, which I'm not going to really go into detail today. And that can be examined through VA Vinci, which is a platform to look at all millions of data. And also phenotyping. So there is a phenotype for all these diseases on the VA database. So it's a wealth of information for anybody who dig into that. And there is also the genetic information for 1 million veterans stored on the VA database and can be accessed for investigators. That's another opportunity. And the VA has a lot of registry for patients with different disease. So there is it's not really a vacuum, but there is a lot of information that can be gained from going through these resources. But the one I want to emphasize today is the VA Cooperative Studies Program, which is a network for clinical research trials, which has been doing clinical trials for 20 years now. And they do it across different VA. These are multi-center clinical trials. None of them is in regenerative medicine, but there is a whole cadre of investigator and clinical research coordinators, program managers who are very familiar with performing clinical trials. So if we can connect this with one of the initiatives for regenerative medicine, I think that will be a very good collaborations. A specific part of this clinical research network is called nodes, which is dedicated enrollment sites, which they work similar to the CTSA in university to try to facilitate translational medicine, facilitating performing the clinical trials. And this network all over the country, but in California, there is Palo Alto, Los Angeles, and we have one, a very good one at Long Beach, and also in San Diego. And these centers also reach out to rural areas. So 2 weeks ago, I was in Reno trying to train some people in the VA in Reno of how to do clinical trials. So we have reach out programs. And I'll show you now that Long Beach VA, for example, has 7 community-based outpatient clinics extended in around 2-hour drive. And I show you the map here. This is the Long Beach VA. And these are the different community reach all the way to Loma Linda. And also there's a lot of network interactions between the different VAs in California. So the Navigate program, I mention it here because this is something I envision maybe in a future that we have a program similar to the Navigate program, which is a collaborative program to bring cancer clinical trials from NCI to the VA. So I envision in the future, and I hope there will be a program, similar program, which can bring regenerative medicine trials to the VA as well. And that Navigate program is very successful program. So our goal will be to establish routine inclusion of veterans in regenerative medicine clinical trials by alliances of VA sites with major university hospital that have the capability to do regenerative medicine. And I don't want to keep you any longer, but I acknowledge the support from your institute, and I'm really grateful for the opportunity to get me in the program in the last minute. So I'm really appreciative, and I can answer any questions. Thank you.
Great. Thanks for that. We're getting down to about the last 10 minutes. I was kind of going to look around the room, and are there questions for any of the last two panelists, comments, anything, any burning questions at this stage?
Doug, I have a question. It's Barbara again in the back. I have a question about kids within this program. I work in the oncology world, and only 4% of oncology funding goes to pediatric cancer research. So I'm just wondering, within the community and within the centers of excellence, is CIRM carving out children and clinical trials, pediatric clinical trials as an area of interest? I know you have funded Dr. Crystal Mackel, for example, at Stanford. Also, Christine Brown is at City of Hope. We have some of the top people in the world in pediatric research in California. So just curious about that.
Well, I think these programs in general tend to be driven by the applicant. So I'm not aware if we've done specific carve-outs. Pediatrics is certainly a substantial portion of our portfolio, and it would be encouraged to the extent there's opportunities there. But I don't think we typically don't carve out in sort of along lines of indications or populations. It's more of.
But within the community centers, would you have a pediatric outreach program to recruit or start pediatric clinical trials?
I mean, I think it's fair to say that there's probably a strong case, and as we heard today, there is a compelling case for why you might do targeted outreach for specific populations. And I think any center proposing such outreach, particularly if it was supported by evidence that they would be particularly successful, say with that population, with that set of indications, would make for a strong proposal. It's kind of
I bring it up. I mean, some of the most promising oncology cell therapy is in pediatric research, and the GD2 CARs coming out of Stanford. So it could be a really interesting thing to do to kind of prove the model.
Maybe I can speak up a little bit, Jeff, about that. So Barbara, that's a great question. I'm behind a screen here. I think that for especially pediatric oncology care, I think it's safe to say, especially with these novel treatments, they would probably need to be performed at the tertiary care specialized centers. But there is a role in terms of some of the other objectives of the community care centers of excellence in terms of education, outreach, and access, so that children in need, especially from remote underserved areas, or even from not so underserved, but not as aware of these opportunities, that these would be something that benefited through the navigation and through some support services, their ability to access these novel treatments and trials at the facilities. And then once it becomes something that's more standard of care, once there's approval and everything else, then the community care centers then will have been involved in certain aspects of this, and this, it'll migrate, that specialization will migrate either in a hub and spoke or a hub and hub model. But in terms of what we've supported, so for instance, the Alpha Clinics network, and one of the Alpha Clinics is a joint partnership between USC and the Children's Hospital of LA, which happens to be a safety net for some of the underserved populations in LA. So it already is being integrated in terms of the infrastructure programs that support the clinical trials. So there is a great starting point for that.
Thank you.
Hello. I just wanted to make sure that we told the last speaker from UC Irvine how qualified and happy we are and honored we are that our new chairman is a former Secretary of Veterans Affairs for the state of California. So if anyone has sensitivity to veterans issues, it's going to be our new chair. And thank you all for an incredible day. This has taken years to put together, and I'm just so inspired by all of your comments today. Thank you.
That was our former vice chair, Senator Art Torres. And hello, Art.
Hey, how are you?
Is this on? Yes, it is. Hi. Hey, Dr. Asa, this is Vito Imbasciani. Hello. I think you're being modest. You said one of the largest health databases in the country with 19 million veterans. I think you are the largest by a long shot. And while I have a request of you. I'm aware of all your databases, or at least a good number of them. I wasn't too, I learned something from you today about the warehousing where all of this data is shared. I'm wondering if you would host a delegation down at the Long Beach VA and give up some of your time to let us go a little deeper into that to see how we might be able to share.
Absolutely.
I'm concerned that we might waste dollars and time by replicating what the VA is, a gem, a national treasure in what it does. The quality of educating doctors, nurses, therapists, every allied. And while you don't have a pediatric population because you have to be old enough to serve in uniform, but you have all the way up to, I'm thinking, thousands of centenarians and a wonderfully rich trove of data. And with specialty, many of the diseases that CIRM is interested in funding, you house these people, you treat them in your clinics down there. So if you would be generous with your time and space, I'd like to visit.
Yes, absolutely. We will be happy to invite you, and just let me know who else will be coming, and we will arrange for you to visit with us.
Great, thank you.
Thank you.
Okay, does anyone want the last word? It's been a long day, so. I am the last word. Okay, so as a reminder, I just want to remind folks about the process. The process is that we are now tasked with taking this wealth of feedback, and I'd like to thank Senator Torres for his kind words about today, because it really was a wealth of feedback. Thank you, Senator. And we will be working with our CIRM leadership, our CIRM board, to begin to develop concepts, and those meetings are in public. Those draft documents may be commented on. So please consult our website and we'll try to, I think we have a mailing list from this meeting. Why don't we also plan, we will do push notifications. I'm going to put Emily, you're going to do that, right? So thank Emily. Emily will do push notifications on the process moving forward, so you're aware of where we are. And we're hoping to have some kind of a proposal ready for early next year. With that.
I think everybody has.
Okay. Slides to be shared as well. So thank you so much for spending a long day with us. We really appreciate your feedback and input.